Good morning, everyone, and thank you for joining us for our 6th annual Patient Safety and Quality Fair. We will start, as always, with We Care message, and Adiola Debiri, our AVP for Quality, Regulatory, and Patient Safety, will be giving our We Care message today.
Good morning. Thank you, Dr. Nakishbandi, for the opportunity. My We Care message today will be on collaboration and excellence. This year, the Institute for Healthcare Improvement has designated March 8 to 14th, 2026 as the Patient Safety Week. This special week serves as an opportunity to highlight the quality initiatives that are taking place at our hospital. These achievements are made possible through the collaborative efforts of our dedicated providers, nurses, ancillary personnel, and support staff. It is through this teamwork that we are able to deliver exceptional care to our patients at the University Hospital at Downstate. Our commitment to excellence is reflected in the experiences shared by our patients. Their feedback provides meaningful insight into the standard of care we strive to maintain. One such example is from our patient who stated, "While a patient at Downstate Medical Center, your strong staff of women left no room for error. Precisely and professionally, they insisted my body obey their rules. And having no choice in the matter, it eventually listened to their unyielding demands." It is so appropriate because it's also Women's History Month. The high standard of excellence that our patients consistently recognize in their experiences with us is the very same excellence we will demonstrate during our upcoming Joint Commission survey. This survey, which may take place as soon as next week, provides us with the important opportunity to showcase our unwavering commitment to quality and safety. We are confident that the collaborative efforts and dedication of our entire team will be evident throughout the survey process, just as they have been reflected in the care we provide every day. Thank you.
Thank you very much, Ms. Debiri, for a very powerful message. And we all know that we're in the Joint Commission period. This is really a critical time. So I appreciate everybody's hard work. We've done it before. We've done a lot of great work. And this is another opportunity for us to shine. Good morning again, everyone. And for the people who don't know me, my name is Rami Nakishbandi. I'm the Vice President and Chief Medical Officer here at SUNY Downstate. Thank you for joining us for our 6th annual Patient Safety and Quality Fair. It's truly wonderful to see many colleagues, physicians, nurses, staff, residents, and students coming together to celebrate and advance our shared commitment to patient safety and quality. Before highlighting some of the important work that we've done in the last year, I would like to recognize the extraordinary milestone for our institution. This past year, Downstate received a historic $1 billion investment from the state of New York. This investment reflects the strong commitment to the future of SUNY Downstate and the community that we served here in Brooklyn. I would like to extend our sincere gratitude to Governor Kathy Hochul, Chancellor John King and his office, and President Wayne Riley, the President of SUNY Downstate, for their leadership, advocacy, and unwavering support to Downstate, the only academic medical center in Brooklyn. Downstate plays a critical role in caring for our community here in Brooklyn, patients who have significant medical need and lower social determinant of health. This past year has been one of the meaningful process in quality and patient safety. For the first time, we achieved Leapfrog B, going up from Leapfrog F. This is a significant improvement in quality and patient safety measures. It's a lot of work that our physicians, nurses, staff, residents, and students do on a daily basis. And this improvement was not just for the inpatient, but we also achieved a lot of quality improvement in the outpatient service as well. We were able to improve in our HEDIS measures for Health First by 1 star in both Medicare and Medicaid. This is significant. It reflects the commitment from our outpatient team and from our managed care team and partners with Health First, and also how we utilize AI in a meaningful way to help improving our quality measures. Our investment is also in our staff. We were able to provide lean green belt training for over 40 staff members in the last 3 years. This is to equip them with all the techniques that will help improve our quality measures here at SUNY Downstate, to have a team will be able to work on improving those quality measures. And the investment also in engaging our staff. Our culture of safety survey was historically high. More than 77% of our staff participated in the culture of safety survey. And they reflected and they highlighted how the commitment of the leadership in improving the quality and patient safety in the institution. The other area I would like to highlight is our transplant program. It's one of the most important transplant programs in Brooklyn because it served a very unique patient population who are having a lot of comorbidities, as I mentioned, lower social determinant of health. And our recertification program, which happened a few months ago, highlighted the engagement of the staff, the improvement in the quality measures, and the process that we have in our institution to improve those quality measures. We had 0 findings in that recertification survey, and this is a high reflection of the commitment of the team, all the multidisciplinary team work in the transplant program. And one of the most important things I would like to highlight is this patient safety fair. This is our 6th annual. This is becoming a tradition at SUNY Downstate. We've been doing it every year in the last 6 years. We have every year around 300 to 400 participants. We presented over 250 posters in the last 6 years related to quality and patient safety. We had a huge number of leaders who, being a keynote speaker or a panelist, discussing really critical topics in healthcare, including leadership, high reliability, AI and artificial intelligence, health equity, safety net hospital, and many, many, many others. All this work reflects the commitment from SUNY Downstate to our patient population, the commitment from you as our team members who work every single day to make sure that we are the best place to give care and the best place to get care. I would like to thank the team member who worked with me very hard to make this event very successful. Dr. Linen Ju, who is our Director of Patient Safety. Eileen, she's still running around, I'm sure. She's been phenomenal in making this event very, very running like a clock. James, our Director of Marketing, Kino Williams, Paulina Botang, Anissa Davis, Abdul, and many, many others. I don't want to forget anybody, but we had a great team working really together to make this event very successful. And now, it's a great pleasure to introduce our new Chief Executive Officer, Dr. Khanna. Dr. Khanna is a nationally recognized physician executive with more than 2 decades of leadership experience across academic medical centers, safety net systems, and large complex urban medical centers in New York City. Before joining us, Dr. Khanna served as the Medical Center Executive Director of the James J. Peters Bronx VA Medical Center. Prior to that, he held several senior executive roles at New York City Health and Hospital Lincoln Medical Center. His service included Chief Operating Officer, Associate Chief Medical Officer, Chief Patient Safety Officer. Throughout his career, Dr. Khanna has demonstrated a strong track record in expanding patient access, investing in community, strengthening quality and patient safety, and developing innovative programs in care delivery coordination. We are excited to welcome his leadership as we continue to advance Downstate mission in providing high quality, safe, and equitable care to all our communities here in Brooklyn. Dr. Khanna will be joining us virtually through Teams. Please join me welcoming Dr. Khanna, our new CEO for Downstate.
All right, thank you, Dr. Nakishbandi. Good morning, everyone, and welcome. I'm Dr. Khanna. I'm very delighted to join all of you today virtually at the annual Hospital-Based Patient Safety and Quality Fair. I'm the new CEO for the hospital, if you have not known that already. But in fact, I'm also a physician hospitalist and a previous patient safety officer. So this concept is quite well known to me, the patient safety and quality. This event highlights something fundamental to our healthcare mission, patient safety and quality are the foundation of everything we do. So every improvement effort represented here reflects our shared commitment to deliver safe, high-quality care for our patients. First of all, I want to thank all the teams presenting today for your dedication, creativity, and commitment. Dr. Rami shared some of the presentations with me and went over that with me. It looks fabulous. Your work strengthens our culture of safety and helps improve outcomes for the community we serve. And special thanks to the organizing team led by Dr. Nakesh Bandi, Adiola, and staff. Congratulations. I also wanted to extend my sincere thanks to our distinguished guest speakers and my fellow colleagues that I've known for years who have nonstop addressed health equity, community health, patient safety, and quality, Drs. Carla Bruton-Foster and Hillary Jello. And I wish I was there today, but I couldn't, and I apologize for that. And thank you for sharing your expertise, being here today, and providing insights about the work that you do. We truly appreciate your commitment and your leadership for your contributions to advancing conversation around safety, quality, and healthcare improvement. Today's program reflects energy and innovation across the institution. I've seen the poster presentation and the oral presentations. Our teams are showcasing today their practical solutions, data-driven improvements, and creative approaches to healthcare challenges. The breakout sessions is going to provide a lot of opportunity for people to cross-pollinate and collaborate. I also am pleased that Dr. Nakesh Bandi has scheduled wellness activities. Without staff wellness, we don't have patient safety. So thank you for that, Dr. Nakesh Bandi. What makes this meaningful and especially important for me, someone like me, is that it's work across the organization. The physician, nurses, pharmacists, trainees, admin staff, and support staff are all working together on these projects. And I really appreciate the effort of non-clinical staff participating in patient safety and quality, which I think is a great forerunner for many institutions. So I want to thank all of you today, and I want to encourage everybody to engage in questions, share ideas, and think about how innovations can spread and even make a greater impact for the hospital and the patients we serve. And I want to thank all of you for your dedication to safety and quality. Dr. Nakesh Bandi, congratulations to everybody. Have a great day of learning.
Thank you very much, Dr. Khanna, for your inspiring remarks and for joining us today. We're grateful for your leadership, and we look forward to working together to continue advancing patient safety, quality, and health equity at Downstate. Let me move back. Okay. We will now move to the next part of our program, which is our panel discussion. Today's panel will focus on health equity as a patient safety imperative, an important conversation that reflects the realities for caring for patients in safety net academic medical center like SUNY Downstate. I would now like to invite Dr. Carla Bruton-Foster, who will moderate the discussion and introduce our distinguished panel. Dr. Bruton-Foster is a professor of medicine and serves as the Associate Vice President for the Office of Institutional Equity at SUNY Downstate Health Science University and the Associate Dean for Office of University Education and Research in the College of Medicine. Thank you, Dr. Bruton-Foster, and to all panelists, and we look forward to a great discussions.
So we really have just a wonderful team of panelists here, and I'm really truly honored to be here because these are, I call them our traveling experts, and and this is a very timely discussion in light of the challenges that are facing health equity and health equity, advancing health equity. So this discussion is really timely. And as Dr. Nakesh Bandi and Dr. Khanna said, it is so important to embed equity in patient safety because we know without equity, patient safety is challenged, and moreover, quality of care is challenged. So today we have an opportunity to integrate discussions on equity with patient safety in our panel when equity becomes harmful, and health equity as a patient safety imperative. And thank you, Dr. Nakesh Bandi, for coming up with this theme. So I'd like to start by introducing our panelists. So Dr. Well, I guess I can just go in order here. So we have Dr. Marilyn Frazier. Dr. Marilyn Frazier is the Chief Chief Executive Officer at Arthur Ashe Institute for Urban Health, a research associate professor in the Department of Medicine in the School of Public Health at SUNY Downstate Health Sciences University, and the co-director of the Brooklyn Health Promotion Center. Dr. Fraser has led and co-led several award-winning NIH and CDC-funded behavioral health interventions, trainings, and curricula in barbershops, faith-based organizations, hair salons. Programs such as Black Pearls and different fades of health programs have received national awards and accolades as well. So these initiatives have focused on educating clients and community members on various health topics, whether it's prostate cancer, breast cancer, colorectal cancer screening, cardiovascular disease, HIV risk reduction. And for these accomplishments and initiatives, Dr. Fraser has received numerous awards for her community impact. Dr. Fraser was recently inducted into the Alpha Omega Alpha Honor Society in the College of Medicine, and Dr. Fraser has been asked to serve on various advisory boards and committees because of her extensive work. So welcome, Dr. Fraser, and thank you for joining us. Dr. Maha Castillo is the Assistant Vice President and Pediatric Medical Director at Health First. And in this leadership role, Dr. Castillo provides clinical direction for programs and activities that transform care for children and that improve member access to care and promotes desired health outcomes for all. Dr. Castillo also provides support for care and utilization management, especially for complex and vulnerable child members. Dr. Castillo joined Health First in 2020 after many years of service as a practicing pediatrician in primary care and in the pediatric emergency department setting. Dr. Castillo has served as an advisory board member for United Hospital Fund PEDS Network, an expert faculty for the New York State Health Equity Leadership Institute, and is currently on the National Advisory Committee for Healthy Steps. So Dr. Castillo is also a well-known and sought-after expert when it comes to health equity and patient safety and quality care. Welcome, Dr. Castillo. Next, we have, you can clap. You can clap for yourselves. Next, we have Dr. Jeffrey Birnbaum, an associate professor of pediatrics and public health at SUNY Downstate, and serves as the executive director of Health and Education Alternatives for Teens, or HEAT. Since 1992, through his leadership role in HEAT, Dr. Birnbaum has provided HIV infection-related medical care to hundreds of adolescents and young adults ages 13 to 29. Dr. Birnbaum is an adolescent medicine specialist who has focused most of his professional career working with HIV-infected youth, expanding access to PrEP services for youth, and has pioneered the field of gender-affirming care for transgender youth in Brooklyn. And his training and his programs are locally and nationally known, and Dr. Birnbaum has received NIH federal funding for his work. He's well known for his advocacy for maintaining the health care rights of our transgender youth. So Dr. Birnbaum is also an alumnus of the College of Medicine at Downstate. Welcome, Dr. Birnbaum. Dr. Amy Afable is the Associate Dean for Community Engagement and Associate Professor of Community Health Sciences in the School of Public Health at Downstate Health Sciences University. For over 50 years, Dr. Afable's research has critically examined conceptual frameworks used to understand health disparities and advance much of our health equity work. Dr. Afable's current research program centers on action-oriented research. So this is really good because we're talking about action and solution-oriented work. Dr. Afable partners with communities in co-designing urban health interventions to address some of New York City's most pressing public health challenges, including those that intersect with the use of digital, that addresses the digital divide. And Dr. Afable continues to address unequal burden of chronic disease and death in historically marginalized populations. Dr. Afable is a well-established researcher and has multiple scholarly work on health equity. Glad that you're joining us, Dr. Afable. And last and definitely not least, we have Ms. Louise Square. Ms. Square is the first New York State Department of Health AIDS Institute Health Equity Manager. And in this role, Ms. Square works with the leadership of the New York State Department of Health AIDS Institute to improve the application of health equity principles by providing training on health equity and racial justice. Ms. Square is the founding member and chair emeritus for the former National Association of Chronic Disease Directors Health Equity Council. She's also co-authored and developed several educational tools aimed at improving public health approaches to equity, including health equity at work, moving to institutional equity, and most recently, she created video shorts to highlight the different factors that contribute to health inequities. Ms. Guerra brings extensive public health expertise and experience that spans over 30 years, which makes her a highly sought-after health equity and racial justice subject matter expert, both locally and nationally. Thank you for joining us. All right. So why don't we get started? So we're going to have a series of individual questions, and I'd like, take 2 to 3 minutes to answer. But we're going to start with a question for everyone, and anyone can jump in for this one. Why are we talking about health equity in the context of patient safety? Why is it important to addressing patient safety?
I can start. I think I'll start because my answer as a public health professional is going to be a little bit different than those who are providers or physicians. And so, by definition, health equity means that ensuring that everyone has a fair and just opportunity to be healthy. Excuse me. And so that fair and just kind of implies safety. But when you think about the question from a public health perspective, I have to ask what we mean by safety. And I did ask Dr. Carla this when I was trying to get clarity on what it was I wanted to say. So when we talk about safety, are we talking about physical safety, environmental safety, psychological safety? Are we talking about, this current environment where we find that people who are undocumented are targeted? Or are we talking about the impact of discrimination based on race? So all of those are things that kind of need to be considered. And also, are you talking about this place represents a safety net, but are we talking about the poor infrastructure of our safety net system within the United States? So those are all things that have to be considered when we think about patient safety. And I think about what the interaction is with the physician once the person comes into the office and all that they bring with them. So in your interaction with providers, is all those things being considered by the provider? Do they know where you live, what you have access to, what your income is, what your circumstances are that you bring into that visit, all the things that have impacted your health before you get there? So in considering this question, when I think about patient safety, I think about it from a different perspective. And while this is all a lot for the provider to consider, sorry providers, while this is all a lot for the provider to consider, it has to be considered in order to think about what this individual will do once they leave your office. How can they carry out your recommendations? How can they do the things that you think will help make them better? And what are their priorities? Is their priority the fact that they don't have enough money to pay the rent? And therefore, if you're providing them diabetes medication that needs to be refrigerated, I don't know if I can keep the electricity going. All those things have to be provided. So, if we're talking about safety within the system, those things should be considered as well, right? If you're talking about the medical errors or medical mistakes, are we thinking about biases that a provider might have towards a patient, whether they recognize them or not? So when we think about patient safety, I guess what I want to sum it by saying is there has to be consideration in giving people the power to talk to the provider, to affirm themselves, who they are, what they bring to the table, and this kind of self-determination in their interaction with providers.
Thank you. Dr. Fabo?
Yeah, I wanted to build on Louise because I am also a non-clinician, one of the non-clinicians on the panel, and I am a population health, community health researcher. But I'm going to speak from the lived experience of patients because, we're all patients, and, a lot of my research is on patient experience, in particular in the maternal health space. But building on what Louise says, I view safety as sort of, if we think about sort of the broader picture in terms of a social ecological framework or I don't know if people have heard about the sort of upstream versus downstream determinants of health. I view patient safety as somewhat of a downstream determinant or sort of individual level determinant, and then equity is sort of this larger sort of concept that is associated with systems and structure, right? And so if you don't have patient safety, if you don't secure, guarantee, or ensure or protect patient safety, right, the implications of that along the way, the health continuum, right, will lead to inequitable care. And so everything that Louise says about, experiences of discrimination, feelings of disrespect, as a patient, feeling dismissed because you express something and your provider doesn't believe you because of, some associated condition, whether it's your social identity, whether it's a, medical stigma associated with weight, or if it's a particular condition, a patient needs to feel safe in order for that patient to receive equitable care. And so that's how I view it from a sort of a larger perspective. And and I welcome the clinician's perspective as well, and how that might agree or disagree with some of their thinking.
Thank you both. I will add to those comments from the clinician's perspective and how I see many clinicians viewing some of the problems that patients come in with as, I was shocked to hear a medical student say, well, that's a them problem. It's not yours to address. And I berated this medical student for having that attitude and expressing it verbally with me and said, no, it's a you problem and it's your job. You're here to address. The patient says something to you about their insurance got cut off or their benefits got cut off or their rent is in arrears. That has an impact on their health and they're coming to you for assistance. So you need to become knowledgeable about that. You need to know what the resources are available to you so that you can address the actual disease. You weren't trained just to treat the disease. You were trained to treat the patient and the environment in which their disease lives, or their health issue lives. So I think changing the culture of medicine and changing the culture of what medical providers go through, and the cultural competence in particular of different populations that we serve is extremely important. Cultural competence on our part about the patients that we serve is something that is essential to improving overall patient safety. I'm thinking about the term patient safety. The patient needs to feel safe just walking in the environment. And if their issues aren't going to be addressed, they're not going to walk into that environment. They're not going to feel safe.
So we've heard from the public health perspective, policy, clinician perspective. So I'm going to just start with our community perspective. And the thing about panel is you have a group of questions and you know what order you want to go to, and then these experts just come and mess things up. So I'm just going to go, which is good, which is really good, this is why you are here. This is why you're here. So you touched upon some really important things. You touched upon broadening health, patient safety within a health equity framework, and really some really important things to consider. Our patients, the patient experience, social determinants of health, how they feel when they walk into the door. So Dr. Frazier, as leader of the Arthur Ashe Institute, nationally known for your community engagements, focusing on trust and mistrust. Yeah. So how do can we discuss this concept of trust or mistrust in healthcare in the context of patient safety?
Oh, yes, definitely. And I agree with all the comments that my colleagues made this morning. And underlying all of that is trust, right? If your patients do not trust you or do not feel as though they can approach you, then they will not seek care. I go back to a lived experience. Recently, my dad passed away about 4 months ago. And during that experience in the hospital, it was really terrible because for my mom, one of the things that she kept on talking about is that wanting to be there every day because she did not trust that they would take care of my dad if she wasn't there overnight. So she wanted to be there all the time, and she couldn't. This is someone that has arthritis and has to move about with pain and so forth. And then I thought also about culture, right? In that sense, food is very important to Caribbean culture as it is to other cultures. And so having my dad eat and knowing that he has had a meal and that has been taken care of was important to her. So when the physician said that, oh, well, we don't care about his nutrition, we care about other things, that resonates to her in what she heard is that you are going to starve my husband, and I cannot trust you to have care. And for her, even to have her seek care post that is difficult, right? She doesn't trust the system anymore, and because her husband wasn't taken care of the way that she thought that he needed to be. And so trust is something that is very important. One of the things that my mom always tells me, it takes a lot to build up trust. It takes a lot of dedication, it takes a lot of time, a lot of energy to build trust, and it could be destroyed just in moments. And so when we think about our communities and going out to our communities, communication is important. It's important that there are those bi-directional communication, that as you talk about, Jeff, sensitivity and cultural sensitivity, that's important. So when we go out to beauty salons and barbershops, hearing from the community, having them at the table, finding out from them what is going on, what are their needs, what does their culture look like, what are the issues that they're facing that they need to be addressed, and then speaking to clinicians also, and so that they can understand the other side, they could understand that we all have our own inherent biases that we come to the table with, and checking those. And when we think about trust, we need to check our biases. We need to think about what are the things that we are doing, how are we caring for the entire patient, that the patient and caring for people as a whole, because they come with cultures, they come with thoughts, they come with a whole lot of other things that are going on before they enter the hospital or before they enter our medical system. So trust is crucial, and it's crucial for us to work hard at building that, but also at maintaining it.
Excellent, thank you. So we've heard public health policy, patient experience perspective, provider perspective, community partnership perspective. So Dr. Castillo, I'm gonna turn to you now as the payer perspective. And thank you for the wonderful work and partnership that we've had with Health First, both educational-wise and advancing health equity. So what are some of the initiatives that Health First is undertaking to advance health equity? And just, I'll add another question to it as well, is in terms of aligning quality measures with health equity. So what are some of the things that Health First is doing, or some of the things that you're considering?
So thank you so much for the invitation to be here. The first thing I think I want to put out there is that we recognize at Health First that we are not the provider, right? That you guys are doing the hard work of providing care, and that we are here to support you in doing that hard work. Right? So I think first and foremost, you said we are the payer, is one of the things that we do to advance health equity is we pay. So we pay you correctly, we pay you fairly, we try to pay for the work that is done. I don't know how many people in the room actually know what the relationship is between Health First and SUNY Downstate, but you guys own us, right? You own us. So we have every incentive to try to make sure that we are working with you in every capacity to make sure that Health First members are taken care of to the best of capacity, and that we pay you. So whether that is through our quality incentives, where we work with you to try and make sure you achieve the highest star ratings, or whether it is by taking all the money that is saved through providing correct care and returning it to you so that you can reinvest it in your system. That is first and foremost the thing that Health First does. I think that it is equitable. We don't have shareholders. We're not trying to make money for people in the stock market. We are returning money to you in the system, and we owe that to you. So I think, that is just kind of the baseline. On top of that, since we are not the provider, we see our role really as working with you to try and improve access, to try and help our members navigate outside of and within the system, and also to educate, right? And so we have so many initiatives that are going on all the time. I'll just kind of highlight a few. In terms of access and behavioral health, we recognize that there was a lot of people who get admitted for behavioral health and then leave, and they end up getting readmitted very quickly because they don't know how to navigate the system afterwards. And so working with our providers that would see a high amount of readmissions, we actually embedded Health First navigators in those specific settings where we were seeing a lot of members coming in to work with the teams, the teams providing care, to help that member then have a safe discharge, navigate, and not get readmitted. And we've seen tremendous improvements in our readmission rates with that, as well as helping our members, when they get discharged, get into the ongoing care settings that they need. As far as education, we have a huge community team where we do diabetes self-management training. We work with communities with the hospitals to do baby showers, where we actually have a health educator that speaks Spanish and English and provides a lot of education, as well as when we have the members there coming up asking questions, helping them try to navigate the system. We have community offices spread throughout the city where we really focus on having people who speak the language, understand the culture, and can help our members navigate anything they need. Additionally, when I came in as the first pediatrician at Health First, I realized we have all these complex members that we are charged, the state actually requires us to provide care navigation for complex members. But if we weren't relating to the provider, we don't know exactly what's happening with those members. So we actually started rounding with the hospitals and the care teams that care for these complex members so that we can make sure they're getting the right care at the right time, and we're helping navigate in a coordinated way. And since then, we've actually brought on an adult medicine doctor who is doing this as well with complex adults. So that's just to highlight a few. We have, many ongoing things, and we're always open to more ideas. So you can reach out to me afterwards if you've got a great idea, and we'll find a way to make it happen, just like Dr. Booten Foster has. So we really value that relationship. Just one last thought in terms of quality measures. CMS did have a health equity roadmap, and there was supposed to be, you guys all know this, a health equity index that was supposed to get involved in that as of 2027. That's no longer on the roadmap, if there is even a roadmap. But the state still sees value in this. We still see values in looking at your quality measures from all perspectives, right? And so I think, it's the long game. It's doing the right thing. I think a lot of times we try to play to the test. So you say, oh, okay, well, health equity is not important anymore in quality measures. And yes, those dollars are very important. So we have to do whatever it takes to make sure you guys get those dollars. But I think the long game and is doing what's right, which is looking at your measures, stratifying them by every different way you can possibly think of, whether it's race, ethnicity, language, zip code, where they live, socioeconomic status, whether they've been in shelters. And we do this, and we help you guys do this by looking at these measures from all these different angles, and we will continue to do that. And I encourage you guys to continue to do that.
Thank you. Thank you. And thank you so much for reminding us that in New York State, we still have the opportunity to do a lot, and while things are changing federally and nationally, we have an obligation. And to look, it's the long game. This is this affliction is short term. Look forward, the long game. So, Ms. Square, actually, yes, you. In terms of talking about what can we do as providers that that doesn't cost money, but not a lot, just leveraging what we have. You were very instrumental in developing the health equity competencies. So while there may be a delay or a lag in what federally is required, but you've set the stage for what we can do. Can you share with us a little bit about the health equity competencies and how we can implement them?
Sure, thank you for that question. I think that's one of the things that I'm most proudest of in my career. As the first health equity officer at the AIDS Institute, one of the things that we know about patients and interactions with physicians is that in the past, even in public health, we blame the patient, right? It was the patient's fault if they didn't carry through the recommendations of the providers. It was the patient's fault if they didn't eat right, if they didn't exercise, all those things. And so one of the things that I thought about was like, okay, what is the provider's responsibility in this interaction? And so we gathered a group of providers around New York State, and we put it out there and we said, hey, what would it take for you to have this health equity exchange with your patients? And at first they said, yeah, we don't want to do this. This isn't going to work. And then eventually they got into it, and we came up with what we call health equity competencies. And so the competencies really outline this way for providers to consider things like the impact of structural racism, a person's social determinants. We've been talking about social determinants a lot. I don't know how many of you or if all of you know what they are, but it's where you, as defined by Robert Wood Johnson, where you live, work, play, pray. And so thinking about those things and thinking about, yes, the provider, you can tell the provider you're homeless, but what happens after that? So we have to think about, have these competencies outline ways for providers to think about collaborating with people outside of that office to even if we can't solve the issue, understand the issue and collaborate with folks to address some of those things, some of those non-medical needs that are identified in the office. And then in our interaction with them, and in outlining these things, we also talked about self-determination, biases, implicit biases that we all have, all of these things. And then in doing that, some of the providers said, yes, we've done a good thing. This is wonderful, but how do we work within our organization, right? Will the organization support this way of interacting with patients, of identifying their social needs, and considering those things when we, whether we're prescribing something or whether we're making a recommendation. And so these same providers Dr. Carla was one of them, who we agreed to keep for just a few weeks, we wound up keeping for 6 months because they wanted to delve in deeper and talk about, I call them organizational considerations for short, but we can send those things to you. They're online. And how does the provider interact within the organization, and how does the organization support that interaction to advance health equity? So these competencies were let out to the world, and then eventually we did a Health Equity Clinical Leadership Institute where we had physicians implement some of the competencies to see how it worked in practical application. And so the long game for this, hopefully, is to get providers early on when they're being trained to be providers, because right now, as far as I know, there's no course on health equity in that training of providers. It kind of alludes to what Dr. Birnbaum was talking about, where okay, that's a their problem, that's a they problem, not an us problem. So the long game is to hopefully implement this in the studies of providers.
Thank you. And Dr. Naqshbandi was also part of that, and as a result of the health equity competencies, established the Health Equity Task Force, looking at social determinants of health, looking at training, looking at patient satisfaction. So thank you, and thank you for, this is implementing, starting from an idea and actually implementing it. So you talked about training. And Dr. Birnbaum, I know you've been instrumental in developing trainings for our UHC trainees and staff and faculty on evidence-based inclusive care, especially for members of our LGBTQ plus community. Can you share some of that work in terms of training? And why is it so important, especially at a time such as this? It's always important, but when it's being challenged on a daily basis, that we really go back to focusing on patient safety embedded in equity and in inclusivity, inclusive care, excellent care. So can you just talk to us about some of the training that you have, and why is it so important that we really just double down on this right now?
Sure, I appreciate the concept of doubling down right now, especially when we're kind of under attack by the President of the United States and the Secretary of Health and Human Services. May they all live interesting lives. Sitting next to Dr. Castillo, I want to just acknowledge Health First has been, you may not know this, has been an incredibly permissive insurer to work with for the types of care, for gender-affirming care, not just for medications and treating gender dysphoria, but also for surgeries. So I just want to acknowledge that since she's sitting next to me. While some of what we do here at Downstate started as a reaction to an unfortunate incident with a transgender man who delivered a baby in our labor and delivery ward a couple of years ago, while the initial impetus was reaction to that, there's been so much proactive activity on a good side that hasn't been reactive to bad things. It's been reaching for quality and safety and making this an ideal place for medical care. I'll start with, and I'll give credit to some of my other partners in this, in particular, Dr. Jacobson Dickman. Together we worked on a curriculum for senior administration in the hospital, and we had a half-day workshop down the hall in Lecture Hall 1 a couple of years ago, which I think would be a good idea to repeat at some point in the not-too-distant future, where people struggled with some of the concepts we were presenting, just language that we use in everyday talk about how we refer to someone's gender, pronouns, and so on, and the negative impact that can have on patients when they walk in. And while it was a struggle for many people, a lot of them realized it's not a me problem. You know, it becomes a problem for them when I can't address somebody with basic human dignity. So while people are entitled to retain their own cultural upbringing and biases, they also acknowledge, somewhat of a split mind, they have a role as a healthcare provider in a hospital and healthcare facility, that their primary role is to take care of the patient first and foremost, and they can keep their private biases to themselves, and that's fine. Their role there is to take care of the patient and make it a safer environment. It sounds like a simple thing, but having group activities and discussions and going through different case scenarios, we saw that for many people it was a struggle, but people overcame a lot of their own biases in the name of better care for the patient. That's at the hospital level. We tried to implement that with lots of different departments to varying degrees of success. It's difficult to get large departments, just not that I'm singling any department out, but the Department of Medicine is huge and sprawling. So it's difficult to organize some of these things. So sometimes you have to be creative in how these things filter into larger departments. The emergency department has been instrumental in fostering change at the local level. And the hospital as a whole, I would have to say the hospital as a whole has been very permissive and supportive of my role. I've been vocal in the press. I've gotten myself into a little bit of trouble in the past year for being vocal. And, but on a macro level, the hospital has allowed me to continue to provide a type of care which the President of the United States is trying to make illegal. So I thank the hospital for just having the proper mindset that this is the right thing to do. On a micro level, there may be things that are frustrating on a daily basis, but if you support them on a macro level, you can address these micro issues one by one as they come up. And the medical school, I would say the medical school, teaching both faculty and students, has been incredibly proactive in terms of shifting the norms of, again, while I'm not speaking about all LGBT care, which I could, in terms of gender-affirming care for transgender individuals, the medical school has put in modules throughout the 4 years of medical school of teaching about the importance of this type of care, and it may seem like it takes on a disproportionate level of importance, but when you're looking at the inequities that result from people just being turned away for care or being afraid to present, and shifting the norms of making it a more welcoming, inclusive environment, it's just a wonderful thing to see from the medical students, how receptive they are, and that, you know, the future generations of medical providers will really change the face of medicine as Downstate graduates infiltrate all over the place. It's a really a wonderful thing to see that the school has really adopted this proactively. So I don't know if I've answered the question, but I talked for a while.
No, but you know, if we think about inclusive, evidence-based, gender-affirming care, that's important to safety because medications, right? Avoiding medication errors or diagnosis errors. So all of those things are really important, and really training our students is really important. And again, going back to, you know, how really fortunate and blessed we are to be in New York State, to be at Downstate, very supportive in initiatives that other places are not allowed to do. So this is really important. Where we are really matters, and to leverage that, to leverage where we are to advance equity and safety. And in terms of being supportive as well, Dr. Afable, you receive support for the work that you're doing. So talk about my expert friends who are doing like good things, like always pushing the envelope just a bit. So Dr. Afable and colleagues, Dr. Douglas, Dr. Frazier also had this idea of patient satisfaction is nice, that's cute, but we need to advance it and talk about equity. So we do a lot of really important patient satisfaction measurements, which is truly important as part of our quality efforts. But we wanted to take it up a notch. So can you just share a little bit about your recent publication in Health Affairs on the BKHI and the development of that?
I also want to shout out Dr. Boone Foster. You were one of the original, concept creators of this index, which is actually called the Brooklyn Health Equity Index. And I also want to shout out to Dr. Nakish Bandi, because he is also working on this project. And some of the unit chairs here, I think I see Dr. Benson. So the Brooklyn Health Equity Index is a 10-item survey. It's designed as a post-visit, post-discharge survey that was developed over the course of 2 years of community-engaged research, which is a team that I was part of. And again, I don't want to take the only credit for it, because I helped usher it through, but there were so many people involved, as Dr. Boone Foster, Dr. Frazier is involved. Also, I want to acknowledge my colleagues at One Brooklyn Health System, Brookdale, Interfaith. They were all part of the original development and design of this index. So in 2022, I want to say, we went out into the community and we talked to you all. We talked to primarily people in Brooklyn, community health leaders, patients. We talked to students at Downstate. We talked to residents. We talked to physicians. We talked to Downstate staff, not just Downstate staff, healthcare staff across central Brooklyn. to ask them, what does equity, health equity look like to you? And so, we talked to about almost 80 individuals across Brooklyn, as I said, different stakeholders that are involved in healthcare and also consumers of healthcare. And so we have a voluminous amount of data that we are still pouring through, qualitative data on that. But based on that data, which was conducted through focus groups and one-on-one key informant interviews, we wanted to be able to crystallize or articulate what the community was telling us, and we did that by developing 10 questions that capture primarily two sort of areas that we've been talking about this morning. One is sort of patients' perception of being disrespected, right? And that, again, as I mentioned earlier, disrespect could be in the form of, actual experiences of discrimination because of one's social identity, as Dr. Birnbaum was talking about earlier. It could be based on sexual orientation, it could be based on skin color, it could be based on someone's accent, right? So we talk about that, but we also ask about being discriminated or being disrespected because of a medical condition, right? If they are overweight or if they have some chronic condition that causes some impairment or physical impairment. So there's that dimension, and it also captures this whole idea of, as we've been talking about, trust and being able to, as a patient, feel that your care team has your back, right? So we ask, do you feel that your provider was empathetic? Do you believe that your provider had an appreciation of these sort of social determinants of health, these other obstacles to receiving quality health care? And so those are the two areas, and we are thankfully rolling that out now at Downstate. We rolled it out already at one Brooklyn Health System. We gathered about 1,300 surveys in that system. And we've been presenting the results, and we've been finding that, in general, there is a proportion that are reporting poor experiences. But the idea is that this measure can capture an overall patient experience, which we think is related to being able to trust your healthcare system, being able to feel that they have their back. And if the patient does feel that, right, they're going to come back and they're going to be more receptive to health recommendations that you might give them. And they'll just be more engaged in their health care and also perhaps being more amenable to behavioral change in areas that are health promoting. So it's a 10-item index. We're rolling out here across 6 departments, and other health systems are also getting more interested in it. So we're currently meeting with Montefiore in the Bronx. They're very interested in adapting it for the pediatric population. So they're doing focus groups now to look at that language. And so we're out there doing that, trying to collect the data to capture patient experience in areas that are not already captured with the current sort of patient experience surveys, such as Press-Ganey. So that's the survey.
Thank you. So if you hear about it, if you have any questions, please reach out to Dr. Fable. So in the last few minutes, we've talked a lot. We talked a lot. Ms. Square, you started out with giving us an operational definition of patient safety and health equity. We talked about the public health perspective, patient experience, provider perspective, and the payer perspective, and community partnerships. So I want to circle back to partnerships. So all of this is a partnership, right? So, and this is a question I'm going to ask of all of our panelists. And you can choose any. What do we do? Moving forward, we have to move forward. We have to look to the future and focus on the things that right now we cannot see, but we know will come. So we have to look ahead. So looking ahead, looking at ahead. What are some of the things that we should do with partnerships, let's say? How should we structure partnerships, education training, policy? So what are some of the things that we can do? We can start with you, Dr. Fritz.
Thank you so much. In terms of partnerships, making sure that you have all the people at the table, making sure that when we are coming together, that we have all the stakeholders. So we have patient populations, we have clinicians, we have medical students. They're the next generation, and thinking through about training for partnerships and keeping lines of communication open. Right? I think we have done so much, and we've heard from all of my colleagues, and so much has been done, and so we can leverage those things and just coming together and really communicating and having that back and forth and being transparent. And really being transparent about what's going on and truthful about what's going on, and really doing what's right. When we all come down to it, doing what's right. And so just really coming together in that mindset of being intentional, that we do want to move the needle forward, and that we do want to train the next generation. We do want to make sure that people are culturally sensitive to things, but really being transparent throughout all of that and being intentional.
Anyone else? What are some of the things that we should do looking forward?
So I think, in terms of partnerships, I think you said it perfectly, Dr. Frazier. It's really, trying to make sure that everybody is on the same page, but with the patient, the population you're treating at the center. And, I don't know if this is so much about partnerships, but I'm going to get a little bit personal here, because I feel like I'm taking in all of these wonderful things everyone's saying, and it's really, provoking what brought me to Health First to begin with, which was I was a physician working, seeing patients, feeling like I couldn't get my patients what they really needed. And then at the same time, I actually had my own patient experiences where I actually experienced some really severe patient safety incidences that affected my life permanently, right? And that led me down this path to say, what can we do as a system? But I think what I'm hearing from everybody here is that there's two levels, but they are one and the same. There's the system level. So whatever it is we do moving forward, we have to set up our systems so that we're taking into account health equity at every level, and that the fundamental basis from which we are starting is how do we make this a equitable experience for each person we treat, and set the system up for success. But then it really is also on the individual level. And I think, what I experienced was I was experiencing really, really bad care in one setting where people were making decisions about me that weren't coming and seeing me. And I could only think in my mind, I wonder if it's because my last name is Castillo that I am not getting people to pay attention to what needs to be. And they're not thinking I'm an attending physician. They're thinking I'm one of those Castillos that they see all the time, right? And then I got transferred to a different hospital setting where I was getting unbelievable care. And it really was about the personal attention that each person was paying to me. And I asked I pointed it out to one of the nursing assistants, and I said, I can't believe how different the experience is. And she said, we have a culture here where I treat you like as if you were my mother, you are my sister, you are my daughter. And I enter each room, each of us enters each room saying, how would I want this person treated if this was my mother, my sister, my daughter, my brother? And that is what I do for you and for each person. And that stuck with me, because I think, we can set up systems all we want, just like we have machines that beep. And what happens? You get beep fatigue, right? And no one pays attention to the system anymore, right? So, but if we also teach each individual to say, I'm going to go into this room, I know nothing about this person. What do I need to do to learn who this person is? Do I know enough about this person, what their needs are, what their desires are, who they are, to be able to treat them and give them the care they deserve? And so I don't know if that's partnership, but I think that's kind of what I'm coming to from this whole panel.
No, thank you. And continuing on what you said in terms of listening to your patients, the person behind the patient, is really important because Dr. Fabre, I know your work in terms of maternal child health and the disparities and inequities that Black women have faced who have not been listened to when talking about pain. So just listening to our patients is really important. So it's building the partnerships, listening to our patients, and partnering with our patients and family members. So would any other of our
I
panelists?
actually have
Yes.
practical ideas about how we might approach, the future of healthcare and really trying to advance health equity. And, I do work at Downstate, obviously, because I teach at the School of Public Health, but I also work with other central Brooklyn health systems, including One Brooklyn Health, and I see some commonalities. But I think, as institutions, at the system level, we need to get better at data collection. And so we all talked about social determinants of health. We developed this Brooklyn Health Equity Index, but there's so much fragmentation in how we collect data and the measures that we use. We need to really be all on the same page. We're all screening for social determinants of health differently, even within our institution. And so I think we need to start working in a collective way to, one, ensure that we have all sort of somewhat uniform measures of what we're doing, because there's no way we could look at impact of what we're doing if everybody's doing something different. So I would recommend we try to put our heads together. There's so much work going, and there's really great novel work out there. We have the data. We have the tools, I'm saying. And we have the tools. Public health has existed for, eons. We've been doing this research, but we can move it into the healthcare system. And Dr. Nakashbandi said earlier, AI is huge now. We can't fall behind. And I think as an institution, if we can gain the trust of our own staff and our patients, right, we can really lead the way, because we do already have the commitment at some level here at Downstate. So I feel like we could be at the, leading the way to ensure that data and AI can move the needle. It is a call for better data collection. And now that we're transitioning into a new EMR system, we have an opportunity to do that. I have a lot of other things, but I'll
Anyone
leave it for
else?
everybody else.
Dr. Birnbaum, Ms. Square, final words in terms of moving forward?
Yeah. I think it's, I'm sorry. Go. I think it's mostly been said. I agree with everything Dr. Castillo and Dr. Flatley have said. But I do think we need to think about, I'm a broken record. We have to think about those influences outside of the institution that impact the work. We're pushing forward, but we know that the social policies that exist are really against us right now. I think we have to take a step back and let me say this, I looked this up. We rank 69th in the world in terms of health outcomes, but we spend more than any other industrialized, medical, moving forward country in the world. We rank 69th. So there's obviously something that's not going right. We have the money, we have the power, we're not getting the results. And so we have to think about those things that impact us outside of the medical office, and we're one of the few countries that don't do that consistently. So I'll leave it at that in terms of thinking about bigger social impact and the work that we do to make sure that we care for our people.
Thank you. Dr. Birnbaum?
Yeah, I just want to add on to things that I said before. I think it's important that we take the temperature of where we're at with creating a more inclusive environment. I mean, I think the issues that are important to me as a provider are just one example of where we could take the temperature. But with respect to that, gender-affirming care and how we make people feel welcome in this environment, what are we doing right? What are we not doing right yet? And there may be things we're just doing wrong. And just getting a handle on where things are, we've made such great strides, how do we make it even better would be my parting shot here.
Well, thank you to all of you. If we can give our panelists a warm, strong round of applause. Ms. Square, Dr. Fabre, Dr. Birnbaum, Dr. Castillo, Dr. Frazier. So do we have time for one or two questions? So if there are questions in the audience, I think we have 4 minutes left. Are there any questions? Yes? In terms of, in the context of patient safety, if we have a transgender patient.
Yeah, I just think those, if I heard your question correctly, those situations need to be handled on a case-by-case basis. It sounded like sometimes there isn't a single room you can give to someone, if I heard you correct. And I think you have to handle those on a case-by-case basis, but if you have a policy in place which strives towards making that transgender patient feel comfortable in the environment, then it makes a difference, even if you can't get them a single room. The fact that you made the effort, speaks volumes to them. So I hope that answers the question, but you have to, these are not everyday occurrences, so it's easier to handle them on a case-by-case basis and try and handle the, create the best outcome in terms of, giving people single rooms and other types of amenities like that when someone's admitted to the hospital.
Yeah. And I'd also like to say is making people feel welcome wherever they are, whoever they are. I'm sorry we're not able to provide you with a room, but we hear you, and because just, it's not there isn't a room and the patient walks out AMA, but it's really that care. It's like, I see you, I hear you, I understand you. What can we do? Let's work together. And treating people the way we would want to be treated, making sure that people feel heard. And I think that cuts across. It's that equity. It's creating an opportunity for people to achieve their best care. And it starts with respect and dignity and making people feel heard. And I think that we don't always solve the problems, but you can always make someone feel welcome. You're welcome here and you belong here. We're going to do the best possible to make sure that you're here and that you're safe. So I think that's something that we can share with everyone. Any other questions?
Thank you, Dr. Boutin-Foster. Actually, I have a quick question and a comment. Dr. Costello mentioned it earlier. A lot of discussions about incorporating social determinant of health as part of the quality measures when we address value-based care. In insurance companies or in the CMS star rating, unfortunately for now, I don't think there is really an incorporation of those social determinants of health as part of how we evaluate the hospital in terms of their performance for the value-based care. Any thoughts on that? Anything is done from the insurance perspectives or from the state perspectives to make sure that whenever we have getting the final results of the value-based care, we make sure we're not just addressing the quality measures, but we link it somehow to the social determinant of health.
Yeah, so actually for the state, there still is measures around social needs, right? Screening for social needs. So we continue to push forward under the New York State, quality programs to encourage and work towards screening social needs. And the 1115 waiver is still in effect. And so we're working really hard to make sure that each person gets screened for their social needs and then gets connected to social needs care network, and that those social care networks are getting paid for delivering those services. So I think there still is a huge push towards that being part of healthcare and acknowledging, at least in New York State, how important that is. for healthcare, and so we will continue to do those efforts. We screen each person that we interact with for social needs. We connect them to social care networks, and we work every day with the providers to make sure that they understand how that's working, that it is working. I just this morning on my way here was navigating a case of a family with one of our care managers brought forward that had reached out to the social care network, hadn't heard back, and I elevated it saying, okay, we got to make sure that the social care network gets back to this family. So I think, there still is a lot being done here in New York State, and there's a lot of dollars in the social care network. So as much as you guys can work to connect people or bring forward if you're finding barriers in the way the social care networks are working, please let us know, let me know individually, let your let your hospital administration know, because we want to make sure this continues to be addressed.
Thank you so much. Thank you for Dr. Boutin Foster, our moderator, and for the panel. That was really great and engaging discussion, and connecting the health equity, the quality, the patient safety is really critical when we serve our community, especially in a safety net hospital like Downstate. Thank you again for joining us. Thank you. We will now move to the next part of the program, our keynote presentation. The theme of that talk is Culture Eats Strategy. It's particularly relevant to work that we're doing at Downstate. While strategies and policies are important, it is ultimately our culture. How we work together, support each other, and prioritize safety every single day. That determines our success in delivering high-quality care to our patient population. It is now my pleasure to introduce our keynote speaker, Hilary Jalone. Ms. Jalone is the Vice President and Chief Quality Officer at New York City Health and Hospital, and Associate Professor at New York University Wagner School of Health Policy and Management. Hilary brings a wealthy experience in quality management from her previous roles in New York City Health and Hospitals, University Hospital Fund, the Greater New York Hospital Association, at NYP. Throughout her career, she has helped to design and manage initiatives to enhance clinical outcomes, reduce preventable readmissions and hospital-acquired infections, and she has trained countless leaders in quality improvement methods. Hilary serves as an advisor board member and is on the faculty for the Greater New York Hospital Association and University Hospital Fund, Clinical Quality Fellowship Program, and is also a member at the Joint Commission Health System Corporate Liaison. Please join me welcoming Hilary Jalone.
So what I want to talk to you about today is New York City Health and Hospital's journey. We've been focused on culture, not strategy. So that's what I want to talk to you about today is our, it's a full strategy, a full culture of safety strategy that we have had over about the past 7 years. And I'm not going to talk about all the elements because we'll be here for a long time. The one thing, Remy asked me to come here, but I have to give major attribution to so many people. I'm not going to go through everyone on this slide, but there were so many people involved in the work that I'm about to describe today. And we did, full disclosure, have a similar presentation to this at the Institute for Healthcare Improvement's annual forum this year. So this work takes a village to get it done, and you heard some of that too from our amazing panelists just before. I do feel like it's a hard act to follow. So what do I want to do today? And I'm going to ask you some questions along the way about your own culture of safety activities so we can kind of liven up the audience to this topic. I want to talk to you a little bit about how we developed a culture that really fostered learning around our patient safety events. So we've done a few things around that. I'm going to show you a roadmap or a framework that we developed with regard to conducting effective root cause analyses. I'd like to see a show of hands. Are any of you here using RCA squared, root cause analysis in action? Just raise your hands. A couple, that's great. I'm going to talk a little bit about that. And then also, just culture. Do you apply the just culture framework here? Just by show of hands. Excellent. So I'm going to show you how we modified ours to make it super simple. So those are just a couple of the objectives. And the way that this will be outlined, I'm going to talk to you about who we are. Some of you, I think, already know who we are, but I'll recap that. And then I'm going to show you our roadmap to culture of safety. It has a lot of elements. I'm only going to go over a few today. So we'll do a deep dive on a few. And then just some lessons that we'll want to share, and then a Q&A. The one thing I do want to say, we just conducted our employee engagement survey. We do it once every 2 years, and we embed the culture of safety survey in that. I am so proud that we went up 8 percentage points just between 2023 administration and 2025 administration of the survey. The other thing I want to say is we had almost a 60% response rate, much higher than in 2023. More than 10,000 additional staff members responded in 2025. So that really was breathtaking seeing that. Our results, we still have a ways to go. We're not ending here, but we have made some fabulous inroads across the whole system because of this roadmap. And I'll end showing you some of that data. But this is who we are. We are humongous. We serve over 1 million patients annually. We have over 43,000 employees, including affiliates, 11 hospitals, 5 post-acute care facilities, plus a long-term acute care hospital. We have a bunch of medical practices, including FQHCs, a community care division, which has a health home and a home care agency. We serve the prisoners. We have a correctional health services. Elmhurst Hospital is the feeder for the women prisoners, and Bellevue for the men at Rikers. Similar to what was said here about Health First, Metro Plus is our health plan owned by us, and we have urgent care services through a virtual express care. And then there's a central office, which is lean and mighty. We're there to support our sites. That's what I always say. My job is to support our sites so that we can be amazing. So this is our strategic pyramid. Some of you that go to King's may know and have seen this. I'm seeing a couple of nods. So we provide care to everyone in New York without exception, okay? So we provide care to our uninsured patients. We provide care to everyone. And what you could see toward the bottom, the strategic pillars, all of our performance improvement projects kind of swim in one of those 5 lanes of quality and outcomes, care experience, financial sustainability, access to care, or culture of safety. In fact, the projects that are reported to our quality board all kind of swim within one of those 5 lanes. And then at the bottom, kind of getting to what the panelists talked about before, in 2020, we added a social and racial equity piece to our strategic pyramid so that all of our performance improvement projects have a health equity lens. And what we try to do with all of them is reduce disparities if we see something. So let's say we're looking at A1C control and we see that there's a disparity among certain patient populations or ethnicities. We will then do PDSA cycles to try to reduce that disparity. And that's a whole other didactic that we could do another time, but we're really proud of that work. Probably about, at this point, 95% of our PI projects have a health equity lens. this is our department. So my amazing colleague, Dr. Eric Way, some of you might know him. He used to be the Chief Quality Officer at New York City Health and Hospitals. He's now the CEO of Bellevue. His department did get split, and these are the areas that I oversee now. There's 12 distinct areas. The usual quality functions are part of that. We did create a whole infrastructure around quality improvement capacity building to make sure training gets out there for everyone that needs it around quality and patient safety. I'll start talking about some of those areas today. Risk management falls under our department, continuing professional education and accreditation. So all the survey activities are under my area. Workforce wellness, right? Because if you're dealing with the surveys and quality, you need wellness to help support that. And then some things that are a little out of the ordinary for a quality department, but are great. We have hospital violence interruption programs at 5 of our facilities. It's expanding this year, and a provider recruitment area that is currently there. It may eventually wind up moving out to the chief medical officer. But what we did back in 2018 was create what we called a quality and safety transformation plan. And that's what I want to talk to you about today are some of these points, and especially points 1 and 2. So what we started to do was we wanted to build a culture of safety. Sounds easy, right? It's not. I'm seeing some nods no. It's not simple. So but our discovery was that at that point, we needed to really instill psychological safety among our staff. And I'll talk about that first. We really wanted to create a culture around improving. Point 2, we wanted to strengthen performance improvement capacity and build really quality improvement capacity across all levels of the workforce, with the whole goal of those that do the work, our frontline staff, are really the most well-positioned to improve the work. So that is the way it is now. It wasn't exactly like that in 2018. And then we wanted to accelerate all of our improvement initiatives. I don't care about the number of performance improvement projects. What I really want to see is real improvement and sustainability, and really swimming in the direction of those strategic pillars I shared before. And finally, we need data to do all this. So when I first came to New York City Health and Hospitals, we had a very old medical record called Quadramed. It's completely out of date, I know. And we wound up transitioning to Epic, and all of our facilities transitioned to Epic right before the pandemic. So it was amazing timing. We could all see each other's data and all the information across the system, which we couldn't do before. So that was really our transformation plan. We are updating this now to make it more current, but the reason I used this is because I really want to talk to you about points 1 and 2 today. So any of you familiar with James Reason's culture framework? Just by way of hands. Great. Okay. So this is what we really wanted to focus on. Really, I'm simplifying it. He has so many papers on this, but what he said is that you need to have these 5 elements to have a culture of safety. The first one being it has to be informed. So you need to really collect data and disseminate it to have a culture of safety. I feel like we did do that at New York City Health and Hospitals, but we've come a long way, especially with advances in Epic. What James Reason also said is we need to have a just culture, so really encourage reporting without fear of punishment. I think that was a little harder. We've made tons of inroads on that, which I'm going to talk about in a few minutes. You need to have a flexible culture, so ways to really focus on changing circumstances to encourage innovations across the organization. And you need to have a learning environment. This was one piece of his framework that I feel was probably missing a little at New York City Health and Hospitals, but you need to have continuous improvement and learn from errors and past incidents. So I'm going to talk to you a bunch about what we've done in that space in a few minutes. And finally, you need to have a culture of reporting. When I first came to health and hospitals, all of the event reporting was done by hand. I remember actually going to King's, and a bunch of residents said to me, how do we even report if there is a medical error? And I said, well, there's this form, I think it's like 5 pages, and you would have to fill it out, and it's one of those, it has like a, the pink sheet at the back so that you have a track record of it. It was kind of old, so of course, residents are not going to report if they have to report using something like that. So I'm going to talk to you about our electronic reporting system in a few minutes. But before that, this is our roadmap. I can't go through all of it because there's so much. I have a wonderful colleague named Jeremy Siegel, who one of these days you probably would want to hear about our Helping Healers Heal program, which is really a wellness program. It was originally for second victims, but now it's really evolved, and it's focused on the well-being of everyone in our organization, regardless of whether or not there's been an event. I'm not going to talk about that today because that's an entire session in and of itself. The areas that I'm going to talk about today really are the ones with the boxes over them, and what I call them are our roadmap to culture of safety. But everything on this from 2018 to 2025 and now really 2026 has helped us achieve that 8% increase just within one time of administering the Culture of Safety survey in our overall safety grade. So we do believe these activities have improved psychological safety and trust. They've empowered staff to really speak up, and I'll talk about some of those areas in a minute. They've increased transparency and collaboration and teamwork. So there's 8 areas that are a subset of what was included on that roadmap. I'm going to talk about 6 today and just a little bit on what we've done in each of those 6. If you want more, you could certainly get in touch with me after this, and our team is always willing to share a lot of the tools that we developed through this. So we developed a framework for humanism and trust in our quality board meetings. We created an event reporting database. We created the framework, it's called Root Cause Analysis and Action, which is the tried and true method for conducting event analysis that the National Patient Safety Foundation endorsed in 2016. Then we developed a system-wide learning framework. It's called an RCA Review Committee, where all our hospitals meet together to talk about our events openly. We created a Good Catch program, and we reinvigorated Just Culture. So some of these activities were already at New York City Health and Hospitals. We just did more of a reinvigoration. So I'm going to give you a little bit in each of those 6 areas, and then what we're doing in 2026 will be at the end of this. Okay, the only reason I'm looking at my phone is because I want to make sure I'm on track with time. So let's talk about the board. Have any of you been involved? Are you all from SUNY Downstate? That's the first question. Okay. How many of you have been to your quality board meetings? Okay, a few. So what I am going to talk to you about is our quality board. I went to one of them when I first started. I wasn't in the quality department. We had to present a bad event. I can't tell you what it is, obviously, because it's confined by the QA privilege. And the person that was the head, I wasn't in the quality office yet, but the person that was the head of my division said to me, "You're going to present the case." And I said, "Okay." And I had heard that the board was a little bit, punitive. They weren't that focused on corrective actions at that point. It was more about what did the provider do? what did the nurse do? That's what I had heard about it. So I was very scared, and I actually even asked her, do you think I'm gonna get fired for presenting this case? I'm gonna come in with an eye towards system issues, but I'm a little nervous. She said, well, you never know what happens in the board. But what a comfort level, right? So I went, I'll never forget it. It was around October of 2017, and it really wasn't bad. We came in with a bunch of corrective actions, but I remember I was literally shaking, and I've been so used to talking to boards in my career. So that was something when Eric Way came to Health and Hospitals and he asked me to work on his team in 2018, one of the things he said to me is, I really want to try to have the quality board become a place that people are okay with presenting cases, right? It's already a very stressful meeting. You're with leadership and the board. Let's try to figure out a way to make it transparent and where we openly discuss our Sentinel events. So that's what we did. That was one of the first steps. So we did this transition. It used to be called the Quality Assurance Committee. So we're very improvement-minded, so we changed the name in our bylaws to the Quality Assurance Performance Improvement Committee. The whole goal of equal parts quality assurance and equal parts quality improvement. So when it was the QAC, there were 175 quality measures that were reported to our, I know, I'm looking at some of the faces in the audience, too much, right? And they were all in a little table format, and you can't do much in terms of trending in a table format. So we decided we really need to have some shared decision-making and figure out what are the most meaningful measures for us to report to our board. Anyone know PSI 90? Good. That's not one of the measures we report to our board. Too complicated, no one understands it, relies on documentation and coding. So we're working on it to improve it, but that's not something that we feel is a meaningful measure to report to our board. So what we did was we came up with this whole voting process, and we came up with 32 meaningful quality measures that are reported to the board. Many of the hacks, so CLABSIs, CAUDIs, surgical site infections, and then other measures that are really important to our communities, like our screening measures, A1C control, colorectal cancer screening. And we do this type of process now once every 2.5 to 3 years to refresh our metrics. In fact, we're in the process of doing that right now. And we got rid of the table. We created run charts. What a good way to include our data. At first, we didn't put any benchmarks on any of the data. We have started to do that because we're ready to do that now. There was so much time spent on this board report preparation. It's really the first thing I heard when I came to Health and Hospitals. You got to meet with the quality office. Like I said, I wasn't in the quality department before. They said, I want you to see the board report. So I did. I spoke with the woman there. Some of their reports were about 800 pages. So who's going to look at 800 pages? We consolidated it, condensed it to the most meaningful. It is still too long. I acknowledge that. But we do report all of the cases to our board. They do see not only the NIPORTs, but they see cases that are reported to the Justice Center and to OMH. And now some of our sites are even expanding and sharing other cases that aren't reported because they feel like they can do that openly. We instilled psychological safety, and I'm going to talk to you about that. Our CEO, Mitch Katz, has anyone seen him speak? Couple people, yeah. He is incredible. He is a people person, and he has a whole focus on we shouldn't be punitive. We should have a just culture. There's accountability, but we shouldn't be blaming people for things that are out of their control, which gets to the last point. In the QAC committee, there was one statement that I had heard, where someone said, congratulations, you still have a job for the next few months, where we went over a case that had a terrible outcome, and Dr. Katz said something like, that was so sad. There was nothing that anyone could have done to do about it. Are the staff okay? And I remember being at the meeting. I'm a sociologist by nature, and I saw that hospital's look. They were just shocked that no one was getting blamed for that case. That was early on, but it was such a clear statement of this administration's commitment to a culture of safety. So, and then the only other thing I would say about this, before each of our quality board meetings, I have a pre-call with hospital leadership to go over the case, the root cause analysis, the findings, and things that I think might come up at the meeting, which I think our sites, probably most of them find it really helpful. And the other thing we did, because we're going over risk management cases, we want to start with a good catch or a good case first. So each site reports a positive case at the beginning of the meeting, and it really sets the tone up so well. So that's really how we changed our culture around reporting to our board, our quality board, and this was one of the first things that we did. So let's move on. Do any of you, do you have an online reporting system at SUNY Downstate? Raise your hand. Great. Okay, some people know, some people don't. We have RL Datix. So we implemented that during the pandemic in 2021. Interesting thing to implement, right? But part of it was because we felt we didn't want to slow down. We want people to report. We want people to feel comfortable reporting. So my amazing colleague, Regina Wallace, leads this work. So basically what she's done with her team, this is through risk management, we've created an online occurrence reporting system. They had a contest among all staff. What do you want to name it? And they decided they wanted to name it Voice, because it's the people's voice. And really, we're using Voice to encourage system learning. All staff can report. All staff can report anything. Events, they can report good catches, which I'll talk to you about in a few minutes, and any safety concerns that they see. And I read a lot of them, too. It promotes, I think, a transparent, open culture, and it also prevents a culture of learning, and we use it in a way that it's not punitive. There's kiosks at our site where staff can report anonymously. It's gone so far, that was in 2021, there's been tremendous increases in reporting, and I'll talk about that in light of good catches in a few minutes. But she's created awards. They want awards for they feel like, wow, we are at a place, our risk managers, where we can give awards out for reporting. So the awards program, which will be really showcased during Risk Management Week in June, it's called the People's Voice Awards. I did not make this up. It was much more creative people than me. And you could see here, there's 7 awards that are going to be given up for reporting. It's really recognition for reporting all around. So we believe that our staff and clinicians' voice truly matter, and that's the way we're going to get better. Okay, now I'm going to talk about RCA squared. I'll do a quick time check. It looks like I'm good. RCA squared, this happened probably around the same time. Everyone was conducting event analysis in a little bit of a different way, and the write-ups all look different. They still all look a little different, but we've come a long way since 2021. So what we decided to do was create training around how do we conduct event analysis. By the way, the other thing I want to make sure you all know, we don't do this with consultants. We do this ourselves. And I know some people are like, wow, when they hear that. But we feel at New York City Health and Hospitals that we know the work better than a consultant knows our work. And that's why we do it. And I know it's hard. I say to my team all the time, I have a teeny team in all those 12 areas. We can do this. And then our sites are going to want to do it too. And that's what's happened between doing it because we've been doing it ourselves. So we did this with RCA squared. I mentioned to you, this is the tried and true method for conducting root cause analysis that the National Patient Safety Foundation endorsed in 2016. So we went through it. It's long, it's complicated. We created a New York City Health and Hospitals version of it with case studies. It's actually a simulated case study, fictitious, about a medication error where the patient got a look-alike, sound-alike medication at the very wrong dose and wound up dying. So, and it could happen anywhere, right? So we created this didactic. There's tabletop exercises throughout it. We started with leadership first, thinking that leadership really has to understand this and embrace it. And then after that, we went site to site to make sure that everyone understands RCA's chiefs of service now want it. So I can't say that in 2021, but fast forward to today, we've done a bunch of refreshers where chiefs of service are involved. If any of you are interested in it, we are more than happy to share. And you can see here, we created a roadmap so that it's easy for sites to understand where there's an event that happens, and then you have a post-event debrief immediately, and the unit department is involved in it, or if it's in the middle of the night, the administrator on duty. And then risk management gets involved as the next step to do all the interviewing and the fact-finding. We're hoping to eventually leverage AI to help us with the event maps. We're not quite there yet, but we want to get there. And then finally, the RCA meeting. So what happens at the meeting and how you can really embed quality improvement tools like process maps and fishbone analysis and the 5 whys when you're doing this work as a full team. And then monitoring is another thing we talk about in this. So you have corrective actions, and now how do we monitor them to make sure that they stick, which is honestly the hardest part for us. So, but this has really helped a lot. I'm now getting frontline staff asking if we can come in and share this didactic and just come to the departments to do this. So the way that we're doing that, we have over 43,000 staff members. We're really engaging the sites in that with us, the quality and patient safety offices at our sites, okay? So that's our RCA squared. I didn't talk about the corrective actions. I talked about monitoring of them. But one of the things that we did was we saw a lot of corrective actions were really in this lower tier of education and training. That's all fine. Staff need to be educated and trained. You need to do a policy change perhaps, but that's not going to create sustainable change, right? So those are what are considered less effective interventions or corrective actions. What we tried to encourage and what we hope to do was really kind of go in the top to the middle of more stronger corrective actions or intermediate corrective actions. Areas like simplifying things, doing some standardization. If we can have an electronic health record fix, let's do it, and then it will be a system-wide fix, which I'm going to talk to you about in a few minutes as well. So really, what we're doing now is measuring the implementation of strong and intermediate corrective actions. That's our measure of effectiveness. So that brings me to the system-wide learning around our RCAs. So probably a little bit after the training was rolled out, around 2022-ish, we started talking with our legal department. We want to create a forum where all the hospitals can talk together about our cases. It originally was rejected because it's confidential information, but we wound up doing a ton of research. So many systems across the country are doing this, where we're sharing our cases openly. We got a bunch of research on it, and we said, we got to do this. Every healthcare system, including a lot of the safety nets, are doing this across the country, and we gave concrete examples. We wound up modeling our program after Hackensack meridians. So the hospitals all come together. An RCA is conducted, let's say it's at Bellevue. We have a presenter of that RCA from a different hospital, let's say it's Elmhurst, present Bellevue's RCA, their corrective actions, and then we think through what are system-wide corrective actions that we want to develop as a group. And the one thing I'll say about this area right here at the top was very important. We needed to have a protected way of doing this. So this system-wide RCA review committee it feeds up through our quality board committee so that all of the information is protected. And then our CEOs all had to sign an agreement that they're not going to share anything from the cases that we discuss. So it's a very protected environment, and creating that infrastructure really helped us have our legal department get to yes on this. But there's been a lot of great system improvements because of this committee. We probably have about anywhere between 12 to 20 system corrective actions per year. This is just a subset of them. The one that I'll just give a quick example of, we had a problem where one of our patients needed a radiology study, and we developed a whole improvement effort around prioritizing radiology studies to optimize the radiology workflow so that the important studies are put right at the top of the radiology tech's work queue. So that was something, again, I can't tell you the case, but that was a great corrective action that's now system-wide because it's done through Epic. But you could see a bunch of different issues here that we focused on through our RCA review committee. So that's the RCA review committee. Now let's talk about the Good Catch program. This is actually my favorite. Raise your hand if you have a Good Catch program. Okay, good. I'm happy to hear that. Do you call it Good Catches or not near misses? And we did the same thing. We decided we wanted to call it Good Catches because it has such a positive vibe, right? So where I used to work, we called it near misses, and it didn't get as much traction. So this is just one example. This is a picture of colleagues at Harlem, but we made up a case. This is the type of Good Catch case that get reported. A nurse is reviewing orders placed by a resident. They noticed a high dose of a strong pain medication was ordered to be given IV. I won't read all of it, but really it was supposed to be given in tablets and not an IV. And the nurse caught this, actually spoke up and said to the resident, "Did you mean to do this?" And the resident said, "No, I did this in error." And it never got to the patient. That is a good catch. So when our staff report issues like this, they get awarded. They get a certificate. And whenever I go to our sites, I see these certificates now all over. Some of our sites even created a logo, like this one up here is a Lincoln Medical Center's logo for reporting good catches. So quality people love the data. This is our data on good catches. We had an increase between 2023 and 2024, but it wasn't that high. Then we did this whole invigoration, I should say, of good catches during Patient Safety Awareness Week last year. And I'm happy to say we had a 35% increase in good catches in 1 year between 2024 and 2025. It's simple to report it. This is a screenshot of what it looks like, and staff are trained on how to report them, and then they are told they will get an award if they report. We want you to report. So that is one program we're very proud of. Just culture. I saw some of you had your hand up about just culture, that you use it here. How many are using David Marks's algorithm? Okay. So we were too. That was way before I got here. That was Marks's algorithm was used. It is the tried and true framework for just culture. Everything that I do at Health and Hospitals, we go around and do market research to see what are people saying about it, what are managers saying about using the just culture algorithm. What they said is, it's complicated. It's hard to use. I'm sure you've seen it. It's like in like a pamphlet. So even though it's a one-page pamphlet, it's really not. It's like 4 pages when you think about it, because it's one of those that you separate the pamphlet out. So we, in our New York City Health and Hospitals, a new way, we decided we are going to reinvigorate just culture by creating a more streamlined algorithm. My amazing colleague Mona Kraus led this work. She's no longer at Health and Hospitals. We have a new patient safety officer named Sophie Ryan, who's really shepherding this work now. But the way we did it, this is our algorithm. You could see it's simpler than David's, and I'm not at all being disparaging of David's, because I think it is amazing. He's the father of just culture. We just needed something a little bit more simple. So you could see here, I'm not going to go through all of it, but if you do want this presentation, Rami can definitely send it around. We have key terms. Our Helping Healers Heal program is at the helm of everything. If a staff member needs to have wellness support after an adverse event. And we define every term. What is human error? What is justifiable choice? And then all the other behaviors, at risk, reckless, on down the line. And then not only that, we say, what do you do in the specific situation? Do you console the staff member that was involved? Do you coach them? Or do you counsel them? And in some circumstances, we have to get labor relations and human resources involved for certain issues. So it's step-by-step instructions. It's a didactic, again, using case studies. There's actually 5 or 6 case studies in it. Again, we share all our materials, so if you're interested in seeing them, that would be great. And we've trained everyone on this newer framework that was rolled out in 2024, 2025, so over 2 years. And now most everyone is using it. I still hear people, because we're so big, saying, what is it? So we always try to provide education to those people that don't know what this is. But as you know, we don't want to have a punitive culture. We don't want to have a blame-free culture. We want to have an accountable culture. And that's what the just culture, user-friendly approach really focuses on. So that's our just culture. And now I'd like to talk to you about some lessons. And I'm great with time, which is wonderful. Some lessons that we learned from all of this. And I'm going to show you our culture of safety data. This is our most recent patient safety grade scores. So I am so thrilled to share this. This is across acute care, post-acute care, and ambulatory care. I said before, we've increased our overall patient safety grade by 8% over 1 year of administering the survey, which is tremendous. We have a ways to go. We know that. I want our goal to be that we are in the 70% for overall safety grade. We're not there yet, but we're getting there. See us inching up. We think that focusing on improving psychological safety and instilling trust, I liked it too, the panel before talked about trust as well. And by this, I'm talking about trust with our staff too, at all levels through the board has helped us in this journey. We also feel that engaging all levels of staff in quality and patient safety, and this focus on systems has really helped, and not focusing on individual providers or nurses or social workers or administrators. And we feel that this systems approach has helped us get to these results. We encourage staff to speak up freely. I think that is super important when you have an event reporting system like Voice to do that, and make sure that they are able to anonymously report. And we really are supporting and nurturing clinician and staff well-being when there is an event. I talked about that before. We're making sure that staff have access to our wellness supports and our Helping Healers Heal program. And finally, I can't say this enough, we all need to do this together as a team, or it's just not going to work out. It's all the way at the top. Dr. Katz has this mentality, and then all of our frontline staff, you could just see it really changing. So for me, it's been it's been the most rewarding job I've ever had to work at New York City Health and Hospitals. And our staff, our patients, everything are benefiting from this work. And I will leave you with that. I'd like to see, Remy, do you think we have time for questions? We have about 15 minutes. 15, yep. So I'd love to answer any of your questions or hear what you all are doing, because I know none of this is new.
I have a question for you.
Great.
This is amazing, amazing work for the staff and for people working in the environment. What about for patients? Is there any consideration around patients being able to report their own safety incidences, and how does that work at health and hospitals?
Wonderful question. Yes. The answer is yes, they do. So first of all, each of our sites has its own complaints and grievances process where everything is, where their grievances are aired. We hope for more complaints than grievances, obviously. And a complete investigation is done through patient relations. If something doesn't happen, then it gets escalated to our president's office, and then our department intervenes. The person, Jeremy Siegel, that I talked about before, oversees all of patient relations. So that's one way. The second way are the patient and family advisory councils at the site level and our community advisory boards. Patient safety topics are discussed there, and opinions of our patients or their families are obtained through those forums, and then the site oftentimes implements the thoughts that our patients and families have. So those are just a couple of ways. There's others as well. One of the other, actually, I'll say one more. We have Press Ganey as our patient satisfaction vendor. So the results, they don't tell you much, right? So a lot of times what we do and our sites do, and we do it together, is we look through the comments, which I think have a lot of great information, especially when a patient is either completely unhappy with the service that we're providing or very happy with the service providing. We kind of often lose the middle in the comments, but some of our improvement efforts around the care experience pillar have really focused on that. Like a great example of that is we think it's probably the patients that are boarding in the ED. So a couple of our sites implemented programs where these ambassadors were walking around and making sure patients who were boarding's needs were met, and they offered like a soup program so that they were able to get a warm food product when the weather was cold. So that's just one really concrete example. I'm even thinking of Elmhurst because they did that. And then there was one other thing I was going to say, but it completely escaped my mind. But those are just a few of the examples. Any other questions, thoughts?
Hi, Hilary. Thank you so much for an amazing presentation. It sounds like you've done some absolutely incredible work at H&H. I was curious, which part of the multiple strategies that you employed were that you found most challenging and most surprising that it was as challenging as you encountered it to be?
Yeah.
Thank you.
So the most challenging, great question also, Wing. The board part was the most challenging for me. I was new, so did not have the trust built from the group. But that's where leadership comes in. People like Mitch Katz and Eric Way, right? They're really sponsoring this. And I think what the sites saw was that our department is filled with people that just want to provide support. It's something that is the mentality of this particular administration is we are not here to be the police. Central office is not the police. We are here to support the sites. So I would say that was one of the most challenging pieces. The second most challenging piece, I didn't even talk about our regulatory surveys. Wow, that was hard. Do you all have, just by way of hands, do you have CMS coming in and out the door here? I'm seeing lots of yeses. Yes, that happens. A person left at Health and Hospitals in our department. It was during the pandemic. And Eric Way at the time said, do you want to lead accreditation? And I said, sure, why not? Having no idea what it entailed. So when I first became part of it, it was, I actually had one site say to me, we do not want you here, Hillary. They were very clear. So I left, okay? But then as the years went on, it just took about a year, they saw our team just rolls up their sleeves and helps. So if you're getting an immediate jeopardy, that's my immediate jeopardy too. And we are helping our sites develop corrective action plans that are realistic and make sense. I've sat with them till 1 o'clock in the morning, waiting for the Department of Health to get out. And they have been so happy about that partnership. We're at a point now with that work, which I didn't share here, we share our citations from regulatory surveys openly. CEOs from one site send all the CEOs their statements of deficiencies now to show them, we had a problem here with elopements and we got an immediate jeopardy. We want you to know what we did so you can prevent that from happening. And then the other thing that we do, there's a leader on our team named Rhonda Reed. She aggregates all of our citations in a way that's non-punitive, blinded, so that we could say these are our system vulnerabilities and not pointing one facility out over another. And what it's wound up doing, one of our chief medical officers went to the screen and she said, that one's ours, that one's ours, that one's ours. It's just created this culture around really openly reporting them. So those were probably the two biggest challenges for us that have become big successes. Did I answer all of that? Yep, okay, great. Yeah, please.
How do you navigate just culture in a union environment?
Aha, yes. I was wondering if someone was going to ask me that.
How do you navigate just culture in a union environment?
And we are a union environment, right? We have many. You can do it. It doesn't take a minute. So I Jonathan Wangle is our labor relations lawyer. So I told him, we're doing this. And we're reinvigorating it. We can't do it alone though. If the unions don't agree to it, we're gonna get nowhere with it. So it took an awful lot of partnership. We created a work group with labor relations and legal, some of our sites, human resources, and quality and safety involved. So that was the first step, is they created the algorithm with us. Jonathan did this with us, and then was feeding it back to the union representatives. We wound up having meetings with union leaders to make sure that they were comfortable with it. It wasn't us saying, we're doing this no matter what. It was us saying, are you comfortable with the way that we modified the Just Culture framework? Does this work for you? And they actually really liked it because it simplified it for them. So, and then the last thing I'll say is with the CEO's support, that was another thing that happened. Several of the CEOs invited us to their labor relations meetings with union representatives so that we could actually share the algorithm with them and answer any questions or concerns that they had about it. But it did not take a short time. I would still call it a work in progress. And as new people come on, then you need to re-educate those new people or start educating those new people about it, because sometimes it doesn't translate back if they didn't get a great handoff. Improvement work is definitely continuous. Hi.
Thank you for all the information. Really appreciate it. So the question I have is that we do feel that the improvement is needed. We do understand that there is an issue that we have to fix it. But how can we overcome two challenges? One, we get defensive about what the issue is, and second, how can we make sure that, how can we enhance or change the culture or change the strategies to make sure that it's non-punitive, but at the same time there is an accountability?
Yeah, and that's the balance. Because I do feel like as you're going through this journey, so I don't have a perfect answer for your question about the balance, because it is. As you're going through this journey, so in an organization like us, we were a little bit more on the punitive side, right? So as you're going through the journey, all of a sudden you feel like, are we becoming blame-free? We don't want that. There should be consequences if there, for instance, is reckless behavior. So we really need to balance the accountability. And we've done that. A lot of it has to do with partnerships with departments, and also partnerships. We just talked about the union, with the union, and for me, it's our labor relations lead, who's really our partner in a lot of this work. And he and I talk about that an awful lot, is we want to make sure people are accountable and doing the right thing, but we don't want to blame people for system issues. So my answer to you is it really does require an awful lot of communication. I've often said this before. Some of what I do in my job, it would be really hard to characterize in a resume, because a lot of it is this very active communication to get at the points of your question. And then the last thing about defensiveness, that comes up all the time in the RCAs. I do think there is a way that you can approach it right at the beginning. This is what I do in any RCA that I lead. I have a script, which I'm more than happy to also share, that talks about this is a non-punitive way for us to go through this case. Here are the elements that we are focused on. In the RCA, we're focused on improving systems issues. And outside of the RCA, we will really apply our Just Culture framework. So I hope that helped. I know it's a little bit art more than science, the answer to that question, but it is something we all grapple with.
Hillary, thank you so much. This is really amazing. And it's fascinating how the great work you build, that culture of safety and building the process and how to improve approaching safety events and great catches. It's very similarly the things we've been doing here. It's actually, we're like looking at each other, that very similar things been happening here, and reflected by the number of cases which we track, the number of incident reports, which we still call it incident reports, that have been going up significantly every year. Great catches is going up every year. Engagement of of the staff in the culture of safety survey went up. We were 4 or 5 years ago around 40% participation. We went up to 77%.
Amazing.
And it's reflected also how the leadership is transparent, how the leadership is supporting the staff, focusing on the system while we hold accountability at the same time. But what's fascinating, actually you didn't discuss it, but part of your presentation today about the violence and the interruption of violence and being part of the equality. In fact, actually, we recently added the violence and the staff safety as part of our daily safety huddle. So we report those on a regular basis since we have all the elements available, the HR, the police, so how we can manage those and make sure that we ensure our staff safety. I would like to hear a little bit more about how that incorporated under the quality team.
Great question. And we're doing some work too about what can we do to keep our staff safe from violent patients. That work is sort of, we're not the main lead for that. That's more human resources at health and hospitals. We are a partner though in that. But our hospital violence interruption programs are a little bit different. What they do is, let's say, a member of one of the communities we serve come into a hospital with a gunshot wound, and they're part of a gang. There's hospital violence interrupters at each of our, not each of our facilities, 5 of our facilities right now. And they actually come to the emergency department and they try to stop the cycle of violence once that patient steps in the door of our hospital. And these programs, they're all a little bit different, but we've created unity around them. They're going to be collecting some standardized data through Epic. And the thing about them that is so great, it's become like a federation of programs. And we do get some funding from the city for each of them. And just to make it a little bit more concrete, some of the things that they do is they create programs for youths so that they could try to encourage them to not be involved with a gang and instead encourage them to do things like breakdancing or art. And what we do now, a leader on our team, Marley Ikowitz, leads this effort. She's created a lot of unification across the sites that have violence interruption programs. And now what we're doing is having events for these youths that otherwise would not have been involved with each other. So we're hoping to develop a peer mentor program for youths that will be more system-wide. But the program is all about interrupting the cycle of violence when a patient comes through our emergency departments. How did it fall under us? That's a great question. I think it has to do with we've been the department who kind of raises our hand and says that we want to do things. So it sort of got handed to us, and what we've done is used more like a quality improvement collaborative approach to it, where the sites meet together, learn from each other, and then implement different interventions together. So did that answer your question? Great.
Well, thank you again. Thank you again, Hillary. Great discussion, very engaging. Learned a lot about your processes, very similar things we do at Downstate, but it just reflects the commitment from the leadership, from your leadership, from yourself to build that program. Thank you very much.
And thank you all so much.
right, good afternoon, everyone. Welcome to the oral portion of our Patient Safety and Quality Fair. Excited to highlight some of the performance and quality improvement projects that have been occurring in our facility, and they're going to present orally. So our first presenter will be Mr. Gerald Eady, and he's going to be presenting falls, fostering awareness and limiting lapses in safety prevention in the emergency department.
Hello and good afternoon. So thank you for the opportunity to share our emergency department performance improvement work focused on fall prevention. Today, I'll walk you through how we identified a growing safety concern, examined our data, implemented evidence-based changes, and ultimately transformed our approach to fall prevention in the emergency department. My name is Gerald Eady. I'm the Associate Director for Performance Improvement for the Nursing Division. This project is titled Falls. It represents a multidisciplinary effort aimed at reducing patient falls in the emergency department through standardization, education, and workflow redesign. I'll be presenting on behalf of the ED team that supported and operationalized this work. This work was not done in isolation. It was supported by a strong partnership between frontline staff, leadership, and executive sponsorship. I want to acknowledge Devin Bennett, my co-team member, and Dr. Cheryl Ralston as our executive sponsor, whose support was critical in moving this work forward. Patient falls in the emergency department emerged as a significant safety concern, particularly in 2023, when we saw a 100% increase compared to the prior year. This prompted us to launch a formal performance improvement initiative. Our aim was clear: improve early identification of fall risk and ensure consistent use of prevention strategies with measurable reduction targets at 3 and 6 months. This phase focused on understanding our baseline. We reviewed fall events, trends, and contributing factors to establish a clear picture of where and how falls were occurring. This data grounded our work and prevented us from jumping to solutions without fully understanding the problem. When we examined activity at the time of the fall, patterns emerged, particularly around toileting, ambulation, and unsupervised movement. These insights highlighted workflow gaps and reinforced the need for targeted rather than generic fall prevention strategies in the ED environment. Our emergency department fall rate was calculated at 0.17 falls per 1,000 patient visits. While this may appear low at face value, each fall represents a preventable harm event. This reinforced the importance of focusing on rate per patient visits rather than raw numbers alone. In this analysis phase, we examined the root causes, or the pain points, variations in practice, and inconsistencies in fall risk assessment. We also looked at how ED-specific factors such as rapid turnover, boarding, and patient acuity interact with traditional fall prevention tools. Although our analysis revealed various pain points, for the purpose of this review, we took a deeper look at the fall risk tool. This deeper analysis revealed that not all fall risk tools perform equally well in the emergency department. This realization became a turning point, pushing us to consider population-specific tools rather than relying solely on inpatient-focused assessments. So data demonstrated that the Kindle 1 tool outperformed the Morse Fall Scale in identifying ED patients at risk for falls. We observed a meaningful decrease in fall rates post-implementation, supporting the decision to transition to a tool better suited to the ED population. This slide represents the formal shift from analysis to action. So based on our findings, we committed to adopting changes that were evidence-based, feasible for frontline staff, and aligned with the ED workflow. Our interventions rolled out in phases, and these included enhanced rounding, EMR fall risk visibility, portable call bells, adoption of the Kinder One tool, and formation of an ED fall subcommittee. So each change built on the last, reinforcing reliability over time. So this is where the work truly transformed care. So fall risk is now assessed at triage using the Kinder One. Fall risk is clearly documented in the EMR banner and discussed during team huddles. Portable call bells and improved handoffs ensure fall risk is visible and actionable throughout the patient's ED stay. So when we look at this slide, these changes represent a cultural shift. Fall prevention is no longer viewed as a checklist item, but as a shared responsibility embedded into daily practice, communication, and accountability. To sustain this improvement, we focused on hardwiring best practices, population-specific screenings, EMR visibility, enhanced rounding, consistent use of safety bundles, and ongoing monitoring through the ED Fall Subcommittee. This ensures the work continues beyond the initial project phase. Our key lessons were clear. One size does not fit all. ED-specific tools matter, and sustainable improvement requires both system design and frontline engagement. But most importantly, small, well-targeted changes can yield meaningful safety outcomes. These were the references, and I want to thank you for your attention and for the work that you're currently doing every day to keep patients safe. I welcome your questions, your feedback, and discussion on how we can continue to strengthen fall prevention efforts across our organization. Thank you. Were there any questions?
Okay, our next presenter is going to be Kendra McDowell, and she's going to be presenting Improved Medicaid Enrollment for New Providers.
Thank you. Good afternoon. My name is Kendra McDowell. I am the Director of Physician Compensation and Billing. I'm presenting our improvement initiative, Improving Medicaid Enrollment for New Providers. This initiative directly supports compliance, revenue integrity, and operational excellence across our organization. This project was driven by a highly engaged cross-functional team. Our executive sponsor, Dr. Nakish Bondi, provided strategic oversight. I served as the team lead, and our provider enrollment experts, Rebecca Ben and Albert Judas, contributed operational insight. Our department administrators from surgery, Saudia Solomon, pediatrics, Lauren Gableman, and emergency medicine, Akila Lewis, played a critical role in identifying workflow gaps. This collaboration enabled us to diagnose the problem and implement a sustainable solution. Medicaid enrollment is the process by which a physician or an advanced practice provider, APP, such as a PA or NP, submits an application to participate in the New York Medicaid program. This enrollment allows the provider to bill Medicaid for services rendered and prescribe medication. Providers may also enroll under the Order, Prescribe, and Refer (OPRA) designation, which allows them to order services, prescribe medication, and refer patients within the Medicaid program. New York State Medicaid and managed Medicaid plans require providers to be enrolled before their start date. The enrollment process takes approximately 4 months. Any delays create operational and compliance risk. When providers begin working without Medicaid enrollment, patients experience delays in care, delays in filling their prescriptions, and claims are denied, impacting financial reimbursement. During our cost-benefit analysis review, we found that between 2023 and 2024, 17 providers generated $49,711 in denied charges because enrollment was not completed. Our goal was to increase the percentage of providers with Medicaid applications submitted prior to their start date from 65.3% to 100%. Our data collection plan included collecting data by conducting structured interviews, reviewing the existing workflow, and developing a process map. We analyzed billing denial data from 2023 to 2024. We also identified providers who began working without a Medicaid application submitted timely to understand the root cause of delays. We used the information we learned to develop a process map. This slide illustrates the previous state workflow, highlighting how the process involved numerous steps and multiple handoffs that contributed to delays and inconsistencies. Benchmarking showed that UHG had 23 providers who began working prior to their Medicaid application submission, compared to just 5 at a peer hospital during 2023 to 2024. Between 2023 and 2024, we saw 180 claims denied because Medicaid applications were submitted late. These delays had a financial impact, with the costs of poor quality for this process totaling $49,711 in charges. Our root cause analysis revealed several pain points. Providers were often identified late in the enrollment process. Workflow steps were unclear with inconsistent notification. Billing sources were unclear or changed. Bottlenecks included provider missing information such as DEA number, New York address, licensure, or NPI number. We implemented a new integrated workflow that aligns hiring, privileging, and enrollment. Department administrators complete the billing section of the initial application request form at the time of requesting hospital privileges. Provider enrollment review all privileging requests to determine Medicaid requirements earlier in the process. Advanced practice providers receive direct support from enrollment staff to complete their application accurately. Finance verifies billing arrangements to ensure alignment with compensation structures. Training for stakeholders was completed in August 2025, and materials were distributed for ongoing reference. This is the initial application request form completed by the department to request hospital privileges. We standardize required fields such as appointment type, malpractice insurance coverage, and billing source to help prevent delays in the process. This slide presents our improved workflow. It highlights the current state process, which has been streamlined to reduce complexities and significantly minimize handoffs. The redesigned workflow delivered immediate and measurable improvements. Between September and October 2025, 100% of Medicaid applications for 10 new billing providers were submitted before their start date. The workflow is now fully integrated into daily operations. Providers are identified earlier, applications are completed more accurately, and compliance risk has been significantly reduced. The new workflow eliminates gaps where providers could start without a Medicaid application by engaging advanced practice providers earlier and providing ongoing support. Application accuracy and timeliness improved. The process is now repeatable across all departments, reducing risk and creating consistency. We achieved full compliance with 100% of Medicaid applications submitted on time. To sustain these improvements, we implemented a coordinated monitoring structure. Weekly reviews of privileging requests, continuous verification of billing arrangements, and routine compliance audits ensure ongoing oversight. We also maintain active communication and feedback loops across enrollment, physician compensation, and billing, and clinical departments. These practices keep the workflow stable, transparent, and accountable. This project reinforced several key insights. Early communication is the strongest predictor of success. Aligning hiring departments, provider enrollment, and finance from the outset eliminated last-minute delays. Identifying providers when they submit their privileging application provides the lead time needed to complete enrollment accurately. Direct engagement with providers ensures applications are completed correctly and on time, significantly reducing administrative rework and compliance risk. This initiative highlights the impact of collaborative workflows and proactive communication in reducing risk, safeguarding revenue, and improving access to care. Thank you, and I'm happy to take any questions you may have.
Two for two, no questions. The next project will be the impact of quality improvement interventions on key dialysis fluid metrics, and the presenter is Hari Vishal.
Hello, good afternoon, everyone. Thank you for the opportunity. My name is Hari Vishal. I'm one of the nephrology fellow working here at the Downstate Hospital. So I'm gonna be presenting a quality improvement intervention on key dialysis fluid metrics. So I'm thankful to my team. This would have not been possible without the team and my executive sponsor, Dr. Sagi. So the question arises here, why the fluid management matters in hemodialysis, why it's important. The fluid overload or improper fluid removal in hemodialysis patient can affect three things. The first one is the cardiovascular risk. Fluid overload contributes to hypertension and eventual left ventricular hypertrophy and heart failure. And the second one that is more common that we see in the clinics and even the dialysis center is the rapid and excessive fluid removal can cause hypotension, cramps, and dizziness. These are the intradialytic symptoms. And the third one is the increased mortality. Poor fluid control is associated with higher hospitalization and mortality. So these are the key modifiable dialysis fluid metrics that we choose. The first one is intradialytic weight gain. It's the excessive fluid accumulation between the dialysis sessions. The second one, post-dialysis weight versus prescribed dry weight, and mismatch may indicate under or over ultrafiltration. The third one is prescribed versus achieved, and ultrafiltration. Failure to reach UF goal may lead to persistent volume overload. So first of all, why this matter for a quality improvement project? So baseline data showed that significant variability in these metrics. that was suggesting inconsistent dialysis workflow, knowledge gaps among the staff, and opportunity for standardized protocol and education. So this was the rationale of our multidisciplinary QI initiative. So here we define the goal, objective, and target. Overall aim was to improve dialysis fluid management using a multidisciplinary QI intervention. The key fluid metrics we targeted here is the intradialytic weight gain, reduce the dialysis session with the intradialytic weight gain of more than 2.5. And the second one is post-dialysis weight versus prescribed dry weight, reduce the mismatch by, which is more than 1 kg. And the third one is the UF goal versus actual UF achieved. So we have to reduce the discrepancy of more than 1 kg. So the question will arise here, why we choose 2.5 kg and why we choose 1 kg. So 2.5 roughly correlates with 3 to 4% of the body weight that has been associated with increased mortality when a person gain more than 3% of the body weight during the, like in between the dialysis session. So the target was simple here, to significantly reduce the episodes of excessive fluid gain and dialysis mismatch within 15 days after the intervention. So this is the examination portion, the study design and the setting in which we did the study. It's a prospective pre and post QI study that was done in single hemodialysis center that was 2-phase. One is pre and the one is post. So we monitored, observed around like 467 dialysis patients, and we collected data pre-dialysis and post-dialysis weight, and we did calculate the prescribed dry weight and the UF goal and the actual UF that has been removed. We did the analysis after a session level comparison and chi-square comparison, and we also got the point percentage reduction report. So I'll give you a break of 5 seconds. We can appreciate here the bars. So when we have intradialytic weight gain of more than 2.5 kg, we can appreciate here 30% of the sessions had a weight gain of more than 2.5 before the intervention. Similar to that, the UF goal versus actual goal removed, the discrepancy was more than 1 kg in 40% of the dialysis. And similar to that, the third one, it's more than 40%, it's almost 40%. So looking at the chart, we can see here clearly approximately 30 to 40% of the dialysis session did not meet the optimal fluid management targets. So that opens a window for us to improve the clinical things and have a better outcomes in the dialysis patient. So we did a root cause analysis. We found some lags at certain level. It was at patient level, nursing level, and the physician level. Our root cause analysis comes from data review, workflow observation, and multidisciplinary discussion. So I'm going to discuss one of them one by one in the next coming slide. So here is the interesting part to me. The first one, patient level, inconsistent understanding of fluid restriction. So some patient had a limited understanding of recommended daily fluid limits, leading to excessive intradialytic weight gain between the dialysis session. And the second one, poor sodium awareness. So this is my favorite picture of sprinkling salt on the food. So many patients were unaware that a high sodium intake increased the thirst, which eventually will lead to the greater fluid consumption and higher fluid accumulation before the next dialysis session. And the nursing level, we do have 3 factors here. So the first one is variability in UF goal. So inconsistent confirmation of prescribed UF targets before the dialysis initiation, and occasional there was a mismatch between intradialytic weight gain, dry weight, and UF prescription that ultimately resulted in discrepancy between the prescribed and achieved fluid removal. The second one is need for refresher training. There was variability in familiarity with fluid management protocol, UF rate, thresholds. So reinforcement needed regarding best practice in assessing intradialytic weight gain and UF targets. So that highlights the importance of ongoing staff education. And the third one, inconsistent escalation protocol. So escalation to physician was not always timely and consistent, led to delayed reassessment of dry weight and dialysis prescription. And third one, obviously, it's me. So physician level, reactive rather than proactive oversight. Fluid management decisions were often made after a complication such as large intradialytic weight gain or the hypotension that has been always there. So rather than going through the routine proactive monitoring. And the second one is delayed reassessment of dry weight. So dry weight was not consistently updated in a timely manner. That eventually was leading to persistent mismatch between the patient's true volume status and prescribed target weight. So these were the three factors we had to work on these. So intervention strategy at every single level that we did was with the patient education, we gave them structured counseling and we provided visual aid regarding, we use certain platforms and we set particular personal fluid targets. Our more emphasis was on sodium restriction. That was a key factor that we observe in the dialysis units. The second one, at the nursing level, we did a pre-session UF goal verification. We did provide like a refresher training, and there was a particular defined escalation protocol that was determined, and then nurses has to follow that protocol. The third one is for the physician, that weekly chart review, and it's a barrier when the patient, like a physician, has too many patients there. So also the second one, dry weight reassessment, and third one is trend-based intervention. So in a nutshell, this is our roadmap, three-level physician, nursing, and the patient level that was causing systemic variability in fluid management. Eventually, we did multidisciplinary intervention that help us to improve volume control and dialysis outcome. So this is the interesting graph. This is the final results. So we can appreciate here, in the previous slide, we saw the red bar in the intradialytic weight gain of more than 2.5 was 29.5. So here it's 9.8 after the intervention. So it's a significant reduction of almost 19.7%. Similar to that in the second chart, we can appreciate it's down from 39 to 4%, so significant 35%. And same goes with the third one. When there was a mismatch discrepancy of more than 1 kg, it was reduced from 40 to 4.3. That's a significant reduction. So that comes the transformation. Overall, was the conclusion from that, that a low cost, it was a low cost multidisciplinary QI initiative can be very helpful to improve the patient outcome in the very end. And it was we made clinically meaningful improvement. And it was like a short study that demonstrated impact within 15 days. And it's also by guiding the nurse to implement certain protocol, it improved the overall consistency, communication, and accountability among the team members. And though it was a small study of 15 days, but implementing these changes create a long-term sustainability plan. So standardized nursing workflow integrated into routine practice, and we continue the patient education reinforcement, and also a weekly physician review for high-risk patient, and ongoing monthly metric monitoring that eventually help us to transform certain things. What are the lessons that we learned here? Is standardization reduce the variability, the first one. The education drives behavior change. Third one, nurse empowerment improves execution. Fourth one is physician engagement, ensure accountability. Fifth one, early staff buy-in is critical, and then implication for future study. So I'll hold to that point. It was done in a single dialysis center. It was very limited for we followed only for 15 days. So a future implementation will be there for sure to improve the patient outcome and the overall, and long-term sustainability analysis and multi-center validation. That was also one of the limiting factors, that it was done in a single dialysis unit. And the last one, and the second last correlation was hospitalization rate, and the last one is incorporation of patient-reported outcome. And these are my references that I have used. So regarding the 2.5 kg and 1 kg that was causing the hindrance. So any question will be welcome regarding that. So, yeah, for future, I would say we'll consider it as a limiting factor because it was done in single dialysis unit. We follow only for 15 days. Though we implement certain things that was regularly being improved with the feedback and it was improving gradually, what we are going to do in the future, we're going to do certain things and monitor for few more days. So it will improve the sustainability in overall. But the regular practice that we implemented was helping overall in the future at the 10th day and the 15 days. It was better than the first day. So overall, it's better in the future. It'll be better. That's all.
Okay, last but not least, we have improving patient safety through proactive WOW Workstation on Wheels cart maintenance. The presenters are Nigel Robertson and Dustin Augustus.
Good afternoon. Thanks for the opportunity to present our project. My name is Nigel Robertson. I'm the Network Operation Manager in the IT department. And my colleague on this project is Dustin Augustus, who's a staff assistant in accounts payable. Our project is improving patient safety through proactive WOW cart maintenance. WOW carts are an important part of patient care. Here we have an example of a WOW cart, and when we use the acronym WOW, it stands for Windows on Wheels. And this comprises of a monitor, computer, keyboard, mouse, and scanner that allows the clinical team to provide bedside patient care or update the patient files promptly. What prompted us to engage in this project is at Downstate, frequent WOW cart malfunctions sometimes contribute to delays in patient care and lead to clinical staff using workarounds. These malfunctions would result in delays in patient medication administration, and it also increased risk of the clinical staff making errors and also disrupts the workflow. Next. Now, in doing the project, we followed the guidelines of Lean Six Sigma methodologies, and we used a lot of those tools in understanding what the current state of the WOW maintenance was to come up with enhancements. So we started off by using a technique called voice of the customer, and that is where we interviewed and spoke to the clinical team, and the project was implemented the pilot was implemented at Nursing Station 61. So we met with the clinical team, discussed what were the areas that they were having trouble with the WOWs, what was working well, and also what could have been implemented to make the WOW function better. We also met with the service desk, who we work closely with on this project, to map out the current state from the start when an incident is identified to when that incident is closed. What we identified during that process is there were a number of pain points that we earmarked for improvement later down in the project. Some of those were long wait time. When an incident occurs, a clinical member might be trying to administer some kind of patient care. They encounter a problem with the cart. When they make that call, it would be quite a while before someone could answer. Of course, that disrupts the service, and that is a danger to patient safety also. We had no preventative maintenance. We discovered that there were not any preventative maintenance schedules in place. So we earmarked that as something to work on later in the project. There was a lack of feedback. Sometimes the technical team will fix the incident, but then no one was notified, so that cart would be still out of use. We also identified there was a lack of report mechanism to run reports to accurately capture how many incidents were reported. So we identified that and later made a change to the ticketing documentation to be able to run reports randomly to identify how many incidents, what kind of incidents, so that we can put a solution in place. Here we have a sample ticket where we implemented a little change that allowed us to be able to run those reports. Here where there's the option for service offering, report incident is necessary to have that option selected so that later on we could have run a report to capture the incidents. As we got into the examine phase, where we actually went out to the floor and assessed the carts, there are a total of 13 WOW carts assigned to Nursing Station 6-1. What we found that of the 13, 7 were fully functional. 6 of them, which equated to 53%, 6 of them had some functional issue, be it scanner, drawers, keyboard. They were having problem connecting to the network, or cart movement up and down. And that phase was conducted August 2025 to September 2025. And that data, we collected that through direct observation, walkthroughs on the floor, and also from the tickets that were reported. What I have here is a graph that plots those incidents that were reported, showing you the percentage and the kind of incidents.
Thank you, Nigel. So after establishing the baseline problem and reviewing the current workflow, the next step in the WEAC framework was the analyze phase. We focused on identifying the root causes driving these wildcard failures, and to better understand why the carts were failing frequently, we conducted a root cause analysis using both the 5 whys analysis and a fishbone diagram. While the initial assumption might be that the failures were purely hardware related, our analysis also showed that underlying issues were largely process and communication gaps. Specifically, we identified not 3 key root issues, but 4. No standardized ticketing information when incidents were reported, no structured preventative maintenance program, limited communication between clinical staff and the service desk, also end-of-life fleet. Because of this, most issues were handled reactively after a cart failed rather than proactively preventing failures. The 5 whys analysis helps us trace the problem further. We found that carts were frequently out of service because they were experiencing repeated functional failures. However, those failures were occurring because the carts were approaching end of life and were not receiving consistent preventative maintenance. Ultimately, the root cause was the absence of structured reporting and maintenance process, which prevented the service desk from identifying trends or planning preventative maintenance activity. So the age of the life of the carts were a major factor. This is our fishbone diagram. It shows the process. So based on the findings, we moved into the change phase where we developed targeted intervention to address the root causes. In October, we focused on solution development, including designing and preventative maintenance plan and creating a standardized WOW ticket category. And in November, we implemented the improvements, which include launching weekly walkthroughs, preventative maintenance inspection, standardizing the incident reporting, and establishing a communication loop between the help desk and nursing leadership team for Nursing Station 61. By December, we transitioned to monitoring and trend analysis to evaluate the effectiveness of the changes. We shifted from a reactive repair to proactive maintenance model. The interventions included creating a standardized incident ticket, like I mentioned before, implementing a weekly preventative maintenance schedule, conducted bi-weekly incident trend reviews, establishing direct communication loop between the help desk and clinical nursing leadership, and just providing the staff with education on proper usage of the cart and the charging practices, because we found that the up and down movement was quite frequent as well. These changes address the root cause identified during the analysis phase. This is our current state process map with improvement made during the improved phase. We added the user notified the ticket, weekly preventative maintenance. We also provided the nurses with the correct email address because for some strange reason, help desk was not receiving when a cart was out of service. So following the implementation, we monitored the impact of these changes, and the results demonstrated a significant improvement. WOW cart availability increased from 53% to 85%, and the service desk incidents decreased from 21 incidents to just 2. We increased the WOW availability to 85% within the 5 months that we started the project. So overall, this represented approximately a 90% reduction in incidents, improving the reliability of the carts used for medication, administration, and clinical documentation. So to ensure these improvements are sustained, we embedded several processes into the standard workflow. These included the weekly preventative maintenance inspection, bi-weekly help desk ticket reviews, ongoing communication with the nursing team, and just continuous monitoring of incident trends. These steps help maintain cart reliability and prevent a return to reactive maintenance. Our future recommendation is, while these process improvements significantly reduce incidents, long-term reliability will require addressing the aging WOW fleet. Future steps include replacing end-of-life fleet, evaluating new vendor options, developing a phased capital replacement plan, and expanding this maintenance model to the other nursing station units. In closing, this project demonstrated how structured process improvement and collaboration between IT and clinical teams can significantly improve equipment reliability and patient safety by shifting from a reactive repairs to proactive maintenance. We were able to increase wildcard availability and reduce operational disruptions that impact bedside care. At SUNY Downstate, our vision is to be the best place to get care and the best place to give care. So ensuring that clinicians and nurses have reliable tools to safely care for patients is a key part of achieving that vision. Thank you. Any questions?
The initial current state or after improvement? Okay.
I think I saw something that you said that there were other parts or something like that.
Say that again, please.
Maybe, okay, yeah, I got it. Thank you. I think they said that if the technician resolve the issue, they will close the ticket. All right. Thank you.
You're welcome.
Okay.
Okay. Yeah, that turnaround time varied depending on what the incident was. Typically, in about 2 hours, the help desk is normally there. But depending on the nature of the incident, if a battery needs to be changed, it could delay some time. Resolve most incidents, yes.
I'm sorry. Is your team going to be implementing what brand of card we ordered? Is it going to be like all across the hospital using the same vendor or card?
I mean, my recommendation is Ergotron, but that's just me.
Well, typically how it has been done and typically how it's done, the IT department would review a number of cards, look at the functionalities based on feedback from nursing, what they would like to have, and then we shortlist maybe 4 or 5, do a fair, and the clinical team would be briefed by the vendors on those cards, and then they do a grading system and come up with maybe the top 3, 4, and then they choose.
So sort of like customized for each unit for what their needs are. Is there any particular vendor you're using right now, or that hasn't started yet?
Let me take a step back. When you say customize, one vendor would be chosen. We will not use Orcotron on one unit, Rubbermaid on another. Typically, one vendor is chosen that provides most, if not all, of what our clinical team needs.
When I say customize, I'm sure that all the, we know, probably, sorry. We may not need all the bells and whistles like Suite A or some other suite. They may need something else, or I may need a lock box in mine so I can lock away patient information while I wheel from basic science to the hospital and stuff like that.
Yeah, well, that's the information you provide to IT, and they'll make that provision.
Yeah, that's
with
what
the
I
vendor.
wanted to know. Thank
and
you.
in terms of if you had a question about timing or something?
Oh, just to speak to that, there's only one vendor that's chosen, and basically what they said, it's based on, it's whoever the staff votes on. So when they have the vendors fair, they have different vendors come, show their product, and I guess it's majority wins, the one that's most voted on. All departments get to come view it and submit their votes. And they kind of choose one that, like a one-size-fits-all kind of a thing. They choose one that would be usable in every area. And some carts, they do have drawers that lock, and some that they don't have drawers. So physicians also use it when they do their rounds. Nurses use it for medication. So it's kind of like a one-size-fits-all kind of a thing. No problem. Any other questions? All right. Just give a round of applause to all of the presenters today. Thank you guys for presenting your projects. We finished a little early, so we're just going to let the judges deliberate and choose the winners. And we'll be back in 5 minutes to announce the winners. Thank you.
Okay, if everyone's ready to take your seats, I think we're ready for the most exciting part of the day, or afternoon at least. Thank you for coming back this afternoon to listen to our oral presentations. So now we have our winners. Dr. Nakesh Bandy will be here to present them, as well as Ms. Eileen Jesse, who is our instrumental logistics expert for this entire fair. So I'll just be reading off the names. If I call your name, please come up on this side of the stage, walk across, accept your prizes and gifts and great applause, and then exit that way. Thank you. Just want to be clear about everything. So the first group, first project that we have selected for winning really gave us a lot of food for thought and gave us a lot of questions in our oral presentation session. So for the project, Improving Patient Safety Through Proactive WOW Cart Maintenance, please come up on the stage, Nigel Robertson and Dustin Augustus. Okay, here you go.
Thank you,
All right, so if you can just walk this way. Here you go.
Thank you.
Thank you. For our next project, which shows us that quality of care is not just about the direct patient care, it's also behind the scenes and all the work that also goes on behind the scenes. Let's have Ms. Kendra McDowell, who featured Improving Medicaid Enrollment for New Providers. Please come up on stage. Our next project that really made a great impact on a lot of patients, on the staff, and amongst our leaders when we saw the results. We'd like to welcome Dr. Desiree Steele, Improving Patient Experience on Nursing Station 81. Okay, and then to recognize our nursing leaders and workforce, the next prize also goes to our nursing group. So this is for Dr. Cassie Griffith, Implementing a Policy for Early Ambulation for Post-Cesarean Hospitalized Patients. And our final group, and you'll see this is like cutting edge, last minute to the T. Thank you, Abby. Our last group represents our physicians and upcoming physicians. So may I have Ms. Alyssa Carlson and Gabriel Cruz come up to the stage. Their project, Addressing Food Insecurity in an Underserved Population through a medical and student-run patient navigator program.
Thank you.
Thank you so much. Thank you. Congratulations. Congratulations to all the winners.
Thank you very much, Dr. Ju. That was a great event. I really appreciate. First of all, I want to thank the team that worked really, really hard in the last couple of months to get this. Actually, we started working on this in October of 2025. So Lillian Ju, Eileen Jesse, James, Keno Williams, Paulina Boateng, Anissa Davis, Abdul. Am I missing anybody? Dr. Benson, of course. Always been, since 2021, she's been with us organizing this event. So thank you so much for your hard work getting this event organized like in a national level. I mean, maybe I'm biased, but it is really in a national level. And thank you so much for attending this great project, great discussions, and we're looking forward to next year. Thank you again.